Hey everyone, welcome to our third sickle cell trait support and information group SCT panelist discussion. As you guys know, it's Pamela here, and I'm joined by experts on sickle cell trait and warriors, as well as fellow warriors like myself. The group was created last year because of me going into such a severe crisis, as many of you guys already know. And since then, we just kind of informally supported each other. Globally, we came together. There's so many warriors on panel. We came together, and this group has just grown and grown, and it continues to grow. And this is us just sharing our stories in the hopes of being recognized and having accessible treatment. If anybody is interested in purchasing my book or finding out more about my story, because this is for my fellow warriors to hear their voices. I've shared my story in a previous session and continue to do so, but due to time today, I'm just going to be really brief and then introduce our first panelist. However, my book is Symptomatic Life of a Sickle Cell Carrier, An Invisible Disability, My Story, and it's available in paperback on all Amazon platforms, on sale until Monday, midnight UK time. Without further ado, I want to welcome my first guest, my sister, my fellow Zambian sister, all the way from Australia, Agnes Nsokwa, and she'll be presenting her sickle cell story and sharing that with you. So go ahead, sis. Welcome.
Thank you, Mape. You know, when you tell a story so many times, you feel like, I'm going to tell it again, but people have heard it before. But anyway, I'll try. So thank you we connected, Mape, because I got interested in your group. I don't even know how I saw your group. I am somebody who lived with this doubt in my mind that what happened to me when I had my fourth baby wasn't right, but I wasn't sure what it was, whether it was because of the sickle cell or whether it was because of something unknown. I had no idea until I met Dr. Tomia Austin, and then I heard from you of what of the symptoms that you experience on a day-to-day life. So for me, my story, even before I had the worst attack ever of my life, where I almost lost my life, I've always been somebody who's anemic. I'm always cold. As I'm speaking right now, I've turned off my heater under here. I've got socks on. I've got, jumpers and a blanket, and I'm always cold. I'm always anemic. At school, I used to actually collapse. I used to just fall down and taken to the sick bay. I wasn't sure what it was. I can't stay in the shower for over maybe 5 minutes. I have to come out because I'm always dizzy. I feel like I'm passing out. But the most severe attack happened when I was pregnant with my fourth child, my second child, and this again came from Wape. I had complications where, fortunately, we didn't lose our son. I was just clothes were coming out, I think around the 4th or 6th month. And I was on bed rest for about 6 weeks. That's something that I don't talk about until Wape mentioned it. I was like, oh my God, this happened to me also on my second baby. But my fourth child, when I was about, 5 into 6 months pregnant, I just had complications that were not so severe, but that were just, like what's happening? I just had fever, to be honest, fever, a sore throat and joint pain. That's it. And over time, I started being anemic. My HP kept dropping. And all the vital signs in my body were just wrong. At one point, when eventually I went to the hospital, because it happened like the first 3 times, when I eventually went to the hospital, I think I went at the right time, because that time the fever never went back down. The other days it would go down if I take Panadol or something, but that day I was in a local suburb. I had to be transferred to the main hospital in the city, and I ended up being in hospital for about 7 to 8 weeks. Out of those 8 weeks, 2 weeks I was in ICU because the doctors had no idea what was wrong with me. That they knew that I was in pain. I was in so much pain, the pain that I've never had before in my life. I didn't want anyone to touch me. I didn't bath for 5 days. until my friends just had to force me, like, it has to be quick, it has to be a minute, I need to be out, because my skin was on fire. And all my vital signs, the doctor said, we know there's something wrong because the white blood cells are high, but we don't know exactly to pinpoint. They tried all pain medications, they tried all antibiotics, and because of the different broad spectrum antibiotics and all the concoctions they are giving me, I became jaundice, my eyes were yellow, I was just passing, blood, and my body was just gone. You could actually feel the life out of you sucking out. And this is how I was like, maybe this is how people feel when they're dying, because I had this in my soul. I had my soul, but my body was failing me. I couldn't walk, I couldn't eat, I couldn't talk. My husband would lift me, my friends would lift me. And everybody came, actually, my mom, everybody back home, they're just like, we don't know what's going to happen. So they tried everything, they failed. At some point I'll be like, I feel like I've got malaria. Before I know it, next time they'll be putting me on anti-malaria tablets. Then they would stop, and then they'll be like, no, maybe she's got a tumor. Then they take me to the main adult hospital. They put cameras under my throat to check maybe I had tumors inside me. And then they stopped that. They just had no idea what was wrong with me. One question though that they asked me was like, oh, we just want to find out, do you have sickle cell in your family? I was like, no, because I had no idea. No one told me. I had no idea. I knew about it a little bit because one of my friends, my best friends actually, was my namesake at school. She had sickle cell, and all we knew was sickle cell. We didn't know whether it was an infection, we didn't know what it was. So I said no, and they took my word for it. They didn't test my husband or anything. They didn't follow it up. So anyway, in trying to find out what was wrong with me, they just started giving me steroids, high doses of steroids. It took me 1 year to wean off. And Dr. Sokolic can explain what that means, to be weaned off steroids for a year. That's how long it took me. I was so swollen. My face was swollen, my feet were swollen. And, it's just fortunate that, I didn't even develop maybe DVT, because I was just swollen everywhere. And then on top of that, I developed diabetic. I developed diabetes. I think it was steroids induced. So after about, I think 6 weeks, I started getting home visits. And slowly, because of the steroids, I started getting better. That's the only thing that started working. And funny enough, they didn't transfuse me. I went back to the doctors 10 years later, like, why didn't you transfuse me? You would have killed me. The doctor wouldn't answer why they didn't transfuse me, because my HB, I don't know how you measure in the US, it was 67%, which was about 6.7 in other parts of the world. And I was pregnant with a child at about now 8 months. They didn't transfuse me. Anyway, the steroids worked, and about 7th or 8th week, I was discharged. And the following month, I gave birth to an healthy child who, in the back of my head as a mother, I knew there was something wrong. And every time any little thing, a call for a sneeze, I'll tell the doctor the story of my life. I almost died. Please do a blood check on her. They didn't. And she had all simple sickle cell symptoms. And without knowing, we just pushed through, would have an excuse every time. She had the hand and foot syndrome. We thought my sister tapped on her fingers because we bought heels for our child. She had pneumonia 3 times, but that was a question mark. Like, I've got 4 kids, but why her? And all those questions the doctors couldn't answer until she was diagnosed at 14 months with an acute chest syndrome. So for me, in a nutshell, that's what happened to me in terms of the sickle cell trait until I met Dr. Tomia Austin. I was like, now it makes sense. Because when I went for a conference, for the ASCAD conference in 2019, I kept telling all the doctors who are doing presentation that, look, I think there's a connection between somebody with sickle cell trait and pregnancy, or just something happens in your body when you have sickle cell trait, because this is what happened to me. Is there any research to show that somebody who's pregnant and sickle cell trait, they can be affected by pregnancy? But there was nothing that they could tell me. And so that's my story. I've never had any attack, but the lightheadedness, the coldness, I'm always cold. I'm always, I can't be in the shower for over 4. That's just my life. I've just taken it that this is the way I have to live my life, because I feel there's nothing I can do about it. Yeah, so that's it. Thank you, Martha.
Thank you so much, sis, for sharing your story with us. I'm just going to deviate slightly from the schedule. So Danielle, would you like to share your sickle cell trait
No,
story?
it's all right. You can keep to the schedule. It's fine. Don't worry. Keep to the schedule.
Okay. Are you sure?
Yeah.
Okay. Okay. So everyone, I'm sure you. I'm giving hands up to Dr. Tomia Austin. She is my hero because since hearing you earlier this year, it just gave me so much hope. And this was when
You're muted.
introduce you to the floor, and the floor's all yours. I just get speechless whenever I'm around you.
Oh, thank you so much. I do not take these opportunities for granted. It hasn't always been like this. It hasn't been so welcoming to talk about sickle cell trait on these platforms. But you, Agnes, we have been able to really extend our reach and join together to bring this global message to as many audiences as possible, and also give voice to those that may feel voiceless, those that are suffering in silence. And I try with every opportunity given to me to affirm you, to acknowledge and absolutely just hear you, just hear what you are going through, because I know that it is not the case in a lot of the healthcare settings here in the US and abroad. And a lot of that is because of just sheer ignorance. People don't know, providers don't know, and they don't know that they don't know. And I don't know which is worse, but our warriors, our trait warriors, are still going and still moving and trying to figure these things out. Some who have been told, well, it's not sickle cell trait, it's something else. And, it just is such a head scratcher for me, because, okay, then what is it? I just want the patient to be treated well and to find answers and to live as well as they can. But we are finding more and more that the typical medical school about sickle cell trait, you will live a normal life, you have nothing to worry about, it is a benign condition. That is just simply false. And your stories and many more like you validate that. So I am going to share my screen and just give you the education that I have compiled, and welcome your questions and discussion. I am Dr. Tomia Austin. I am a PhD, not a clinician. And this is sickle cell trait education. I am the executive director of the As One Foundation, where our mission is to empower families globally by delivering life-saving sickle cell education. This organization was established in 2007. That young man on the screen is actually an identical twin. His brother, Devon Darling, they were both born in Nassau, Bahamas in 1982. They would learn to love all things American. They loved the American game of football, and their parents would divorce, so they would move to Houston, Texas, and that would become their second home. That is where they got to really engage in the American game of football, because it is not played in a organized way. It's not a funded sport in the Bahamas. But they were also great academic students as well. Long story short, they were recruited nationally and chose Florida State University in Tallahassee, Florida, which would allow both of them to come and play. The twins played opposite sides of the field. Devard was an offensive wide receiver, and Devon was the quarterback, if you will, of the defense. And They had shared dreams, they had shared goals, all of their young lives. It was pretty peculiar, as the story is told, how these young boys always had written goals and dreams. And one of their dreams was to play college football in the US. And they wanted to play together, and they did. They were accepted into the Florida State community. And that is also where they learned that they had sickle cell trait, because we do have the National Collegiate Athletic Association here that, just to give you some context, there is a mandate that all NCAA athletes be tested for sickle cell trait. This mandate did not come of the goodness of the hearts of the leaders of the NCAA. This is what we call in the US CYA, cover your bleep. This was about liability protection for the NCAA, because there had been athletes who passed before from this sickle cell trait exertion. And so there was the mandate to test the athletes, and to, they created an 8-minute video. But there's, it's still a few holes in the whole process, even though the research has proven that it has increased some prevention. It is still not enough, because this mandate is there and the deaths continue. And unfortunately, on February 26th, after the twins played as true freshmen, they started and they fell short one game of an undefeated season. They lost the national championship their freshman year. And so the way the US football system is, you start playing around August and you play all the way through the fall. And you usually, if you excel, you play a championship in January. And so January of 2001 is where they almost had an undefeated season. They almost won the national championship. So come February is when the off-season workouts begin. Some of them voluntary, some of them, it's the unwritten rule is voluntary, but everybody shows up. And at that time, Florida State University was known for these vigorous killer mat drills. And it was the way of the coaching, mindset to whip these guys into shape, make them go through the wall. Let's see how hard they go. And that is a culture that has now been adopted by the young athletes themselves. So coming off of an almost undefeated season, come February, they are like, hey, we almost won every game. We're going to go harder. We're going to prove that we are worthy, and we're going to win every game next year. And they were going through mat drills on February 26th, exercises where each athlete is measured by their ability to continue. Without breaks, without hydration, it was a tradition to do the protein spill, which is to vomit. And vomiting is automatic dehydration for any of us, sickle cell or not. They were coached, your body is amazing. You will pass out before you die. And unfortunately, Devon did pass out, and he died on February 26, 2001. So Devard would be forced to move on and live his life without his identical twin brother, and had to teach himself about sickle cell trait, what it was, why did this happen? And ultimately he started the Aswan Foundation to honor the memory of his brother. And then later we adopted the sickle cell trait as part of our mission to increase awareness, specifically because of these prevalence, the facts that it is, so common, the most prevalent genetic disorder, and the fact that it's considered benign, and Devon's death proves that that's not the case. It is also riddled with myths about who it affects. The general consensus is this is something that affects Black people or people of African descent. And when the facts are, it affects people of Latin, Asian, Indian, Mediterranean, Greek, Turkish descent. And the next largest population is Latins, and in India, the numbers rival the African-American numbers. So this is not just a Black skin condition. This is a global condition, and with migration and mixed race births, anybody can be a sickle cell or sickle cell trait warrior, absolutely anybody. And that's why we say sickle cell trait matters. It's a genetics thing, not a skin color thing. And we encourage testing. We encourage you to know your trait status. And it's a simple blood test. We recommend the hemoglobin electrophoresis to find out. But just to roll back a little bit, just to give you again, these are the myths that the As1 Foundation was established to address. In the Bahamas, when the Darling twins were born, the parents, the doctors were all expecting one baby that day. As throughout that pregnancy, they had been hearing two hearts beating as one. And that comes back to our present when Devon passed away, when Devard switched from Florida State to Washington State. He played 2 years there, and he played every game with a picture of Devon inside of his football pads. And when he would score or make a huge run, he points up to the sky to honor his brother. He would eventually create or establish the As1 Foundation in memory of his brother in 2007. So that's where the foundation gets its name. I was on a webinar yesterday where I told the story of when I had the light bulb moment, because our name is As1 Foundation. And those of you that are very closely engaged in this sickle cell trait world, you know that AS is the genetic name of sickle cell trait, because there's one adult hemoglobin copy that you get from one parent and one sickle hemoglobin copy that you get from another parent. And so that AS1 Foundation, oh my God, at the moment it just kind of stuck out to me. Now, Devard had no idea that AS was the genetic name of the condition that was running through his blood when he named this foundation. But we know that some things are not real coincidences, they are divinely decided. So just a note to give you more background about the As1 Foundation. But we work to combat some of these myths. As I said, sickle cell trait is benign, nothing to worry about. You'll live a normal life. It affects only Black people. And then the stigma, because the trait testing that's been mandated here in the United States, which is actually, coveted around the world, there's still not universal screenings around the world, but the screening process here in the United States, especially for the athletes, that's been mandated by the NCAA, is criticized because of the potential of stigmatizing athletes. And but I did my own research when I was in school about their sickle cell trait literacy, and I can tell you the athletes themselves do not feel that. They feel that an athlete who's out there on the field, sickle cell or not, if they're there, then they deserve to be there. And they want to know. They want to know if they have it. They want to know if their teammate has it, because they want to be involved if there's an opportunity to help save their teammate's life. So I'm always advocating for, when these decisions are being made, are the trait warriors at the table that you're making these decisions for? Have you asked them? Because I did. And in asking them, they said, yeah, we want the education. We should be tested. We should be getting this education in middle and high school. And we want to know. We're not ashamed of it. It may be quite of a different story in professional sports because of the ignorance that's there. And, if you have a professional coach or a professional general manager that is thinking that sickle cell trait can be limiting, I won't get my money's worth out of this player, then that's where it can be a bit of stigmatizing there. But we're working. All of these complications that are listed in emerging research, here's the proof. Not that I need this proof because I listen to you all, but chronic fatigue, splenic infarction, pneumococcal disease, thromboembolism, retinopathy, kidney injury, and even the cancer, renal medullary carcinoma, where statistically 100% of people with renal medullary carcinoma also have sickle cell trait. Acute chest syndrome has been associated with trait, avascular necrosis, exertional sickling, which is what happened to Devard and a number of other athletes, sudden death, and even most recently, COVID-19. The chronic fatigue, tired for no reason. I've had sickle cell trait people tell me that I met this 48-year-old woman who was retested, because that is also key, is to really get a clear and close diagnosis of what the hemoglobin electrophoresis is the recommended test. This test will not only tell you and confirm your trait status, but it will also give you a percentage of the abnormal hemoglobin, the S gene. It'll give you the percentage, which can give you an indication of whether or not your symptoms, will be high or not. It's, again, I'm not a clinician, but the electrophoresis is the recommended test to be able to start checking off these boxes and answering some questions, finding some solutions. But I remember speaking to this 48-year-old trait warrior who not only found out her status, but she ended up having an apology received from her mother, because her mother had accused her of being a hypochondriac all of her life. You're just lazy, you're always tired for no reason, when in fact it was directly related to her sickle cell trait. So chronic fatigue is a thing, it's a real thing, and it is highly associated with sickle cell trait. The splenic infarction caused by high elevation, that's what can happen rather when flying, or if you've heard of Ryan Clark, the Pittsburgh Steelers National Football League player who was playing in Denver and ended up having multiple organs having to have them removed because he went into, he had a splenic infarction and just started to shut down, and he has trait. The pneumonia, I won't get into these because we do have our doctor here with us, but these are all, and I've listed the research at the bottom where this information, one example, because there's some of these are found in multiple sources of where these associations, these complications have been associated with trait. Thromboembolism is pretty common. And again, this is a blood condition, and wherever you have blood in your body, you can sickle, especially when you access the perfect storm, I call, of dehydration and elevation and exertion. Retinopathy, that's something that's spoken about a lot in sickle cell, but retinopathy can also be a complication of trait carriers. And the kidney connection is complex because all blood in the urine is not the RMC. The hypostonuria, the inability to concentrate the urine, so there's the bedwetting. Rhabdo, from working out, you have the muscle tissue breakdown in your blood, and that's, you can have that with or without sickle cell trait, but pretty much all the time with sickle cell trait, there's hospitalization, and unfortunately, often death associated. And then the big one, of course, is the RMC. The big controversy here is when RMC is present and found, is usually not diagnosed until late stage. And the hope and prayer and work that we are expending is to find a way to have RMC diagnosed early, because there have been cases, and even though, I take such issue with rare, the word rare, because it just connotates not important. And it is important. You tell Wendy Darling, who lost her son, her son on February 26, 2001, that what happened to her son is rare. It matters not. That was her son. And she even had an identical to him, and she still misses her son. So that whole rare thing, is subjective. But the renal medullary carcinoma can be diagnosed early if there's a way to look closely at the kidney and diagnose. And I know of cases where, when diagnosed early in stage 1 or 2, it was able to be treated and reversed, and the carrier lives on. But these late stage diagnoses are almost always fatal within less than 2 years. Acute chest syndrome. This is, I listed 2 places in research where this is, associated with sickle cell trait. Again, whether or not sickle cell trait is the cause, where some clinicians will say it's not the trait, it's something else, then treat the patient. Let's treat the patient, let's treat the symptom, and let's worry less about the label. And hopefully conduct more and more research, so that if it is associated with trait, if it actually is, then we can start, raising more awareness, especially of the physicians who in a lot of instances are undereducated and underexposed, and which causes our trait warriors to end up having to educate their own doctors. Avascular necrosis. This is the one very commonly associated with this is the clinical diagnosis of what people describe as growing pains. If you're 48 years old, it's not growing pains. You're done growing that way. I mean, we can add girth, and steroids can make us look different, but growing pains are not occurring at 48. But it is important to know that, with the sickle cell warrior, the disease warrior, that necrosis is not one incident and it goes away. It's compiling. There's tissue damage in there, there's tissue death, and similar could be happening in our trait warriors, with having to have hip replacements and various things because of the bone death and tissue death that's associated with avascular necrosis. And then the exertional sickling, which we at the As One Foundation, we pay quite a bit of attention to, largely because that is how we lost our inspiration, who has been gone 20 years this year. Devon's memory is honored in every opportunity we take to educate, in every activity that we do, to ensure that his death was not in vain. No college student playing college football should die of sickle cell trait exertion. It just does not have to happen. Universal precautions, screening, hydration, not working these kids to death, allowing them to go from rest to exertion gradually, to allow them to get hydration before, during, and after, and to allow them to get workout recovery breaks. That's the difference between these young athletes living and dying. And even COVID-19, respiratory issues, the embolisms, the blood clotting, all of these are in recent research. So please, if you're screenshotting it, read it for yourself. It's there. The exertional sickling is also, raised the attention because of these young athletes, and because also it looks so much like other things that we see, like cramping, hammies. Devard in the NFL said he suffered hammies. Well, was it hammies, or was he, having a crisis in his thigh? That's the question. And if this goes unchecked, especially if an athlete ends up going completely down to the ground, as in this slide, if they take a knee or walking around with their hands on their hips, or raising their hands above their head in the cobra position, and are able to actually get the oxygen back into their lungs and find recovery, that's great. That is common, recovery practice. But when you are seeing after, especially after brief high intensity workouts, most of these deaths for these athletes occurred in the very first day of practice within the first hour. That's the number one telltale sign. It does not require extended activity. It's brief. And then, the pain that takes them all the way down, they're complaining of cramping or struggling to recover, we're in the danger zone. This is what it looks like, and this is how it is often described, which has given it the label of being the number one non-injury killer of collegiate athletes here in the US. So as I said, the NCAA mandated that testing take place. At first, they were only saying just Division I, which are the larger schools here in the US. But then we had an athlete by the name of Dale Lloyd out of Rice University in Houston, which was not a D1 school. I believe it was a D2 school. His parents, of course, they sued the university, but they also wanted his death to be meaningful. So they worked with the NCAA and got them to expand their mandate to not just D1, but D2 and 3. And believe it or not, we still have other leagues in the United States that do not mandate the testing, but all divisions of the NCAA schools do. And while they have been able to boast some change, the education is still key because the deaths continue. And these deaths continue because of the three main risk factors, as I said: dehydration. And by the time you're thirsty, you're usually beyond dehydration at that point. Elevation. The elevation, that can be affected in flying, traveling to Denver. And it's not just high elevation, it can be low elevation, like deep sea diving. Just a threat to your oxygen. And then, of course, the exertion. These are risk factors that have to be paid attention to when you have trait, especially when you engage in physical activity. And this is not just football athletes. This is not just athletes, marching band, dance, or if you are a physical laborer out there working on bridges, or, farmer, any exertion, that does become a risk factor for trait warriors. It doesn't mean you can't do it, but you have to be aware of the risk factors. And as I said, this is the top non-injury killer of athletes, but then you need to also be aware of the protective factors. Here are examples of athletes here in the United States who died. And although their death certificates don't say their death was caused by sickle cell trait, because sickle cell trait does not have a cause of death code here in the United States. It is usually listed on the death certificate as a secondary contributor. And that's another thing that we are working to advocate for, because if a lot more deaths have occurred because of sickle cell trait and they're not being properly recorded, then those are, they're clipping our wings, the information is not being captured in a way that we can present it back and say, hey, this is killing too many people. But often their death certificates are saying, heart attack or heat stroke or other things. And the sickle cell trait is listed as secondary, which basically skews the data and gives you a different impression of what the actual death rates are. And unfortunately, these are peewee, middle, and high school students that we are aware of. This is certainly not all of them. And you see Carson there to the right, my right, the white fella. He has sickle cell trait, and he was 17, I believe, 13, excuse me, he was 13. First day of football practice, within the first hour, he went into the exertional collapse, and I believe he died within a day of that collapse. So what is being done? We do have the newborn screening program here in the United States. But as I said, if there's a positive diagnosis of sickle cell disease, then they are immediately called, associated with a hematologist, and pretty much are handheld throughout the illness of sickle cell disease. But with trait, it's a very different story. If there is a notification, it's usually by mail, and it's one page that has 3 bullets that basically says it's not disease, you're gonna live a normal life, nothing to worry about unless you have a baby with someone else with trait. And then, so there's that 25% chance of birthing a child with disease. And very little, if at all, follow-up. And when you get that letter and you have a brand new baby and you're just told, but you have nothing to worry about, where does that letter go? Into that junk drawer, into the trash, thought of no more, because they just told you, don't worry about it. It's nothing to worry about. The next time it comes up, possibly, is if that baby wants to play collegiate sports here in the United States. That is the next time that there is any type of mandated information about sickle cell and screening and so on. So yes, we have the newborn screening, and we are grateful that we do have it, especially with the knowledge that so many other places do not and are striving to get it. But we have lots of room for improvement. As I said, what happens? Is there discussion during childhood? What's the parents' knowledge? Because they don't get that phone call. They don't get the follow-up. Everyone's not doing that. The As One Foundation is, but we're a small organization, and we have 300 million people worldwide that we need to have conversations with. What's the child's knowledge? Like I said, there is no other screening mandate unless they go to play collegiate sports. And what if they don't? What if they just want to be in a marching band? What if they start dancing? What if they want to do their bucket list and run a marathon? And we've heard of people dropping dead at the finish line because they didn't know and weren't properly prepared. So as I said, there are 3 current sickle cell trait conversations that we've identified here in the United States. At diagnosis, if they play NCAA sports, they have to take that test. And by the way, they actually can opt out of the test if they can find their newborn screening, or after it's too late. They've been hospitalized, they've collapsed, or unfortunately they've passed. Those are the 3 times where the sickle cell trait conversation is guaranteed. Here is where I propose we have more conversations. Certainly at the family planning stage, when dating and considering which goes hand in hand with the genetic counseling, educating and universally educating. I'm skipping back and forth, but as we see what happens every October here in the United States, and I do believe globally with breast cancer awareness, the world turns pink. There are pink cars, pink footballs, pink towels, pink hair dryers and irons. We need, everybody's getting educated about breast cancer, but everybody's not going to get breast cancer. So everyone needs to be educated about sickle cell trait, sickle cell similarly. Another time, is of course in diagnosis, recommending the more sensitive tests, not just the STREC or the Sickle Dex, finger prick, the hemoglobin electrophoresis test that will actually give you your percentage of abnormal hemoglobin. In school testing and education, we have sex education here, we have home economics here. Those are pretty good times to start talking about sickle cell trait. And transition is a big word here. Transitioning the sickle cell pediatric patient to adulthood. This also is a time to discuss for the trait warrior. Start talking now about their needs for hydration, their need, for education, looking at their body and understanding their needs versus anyone else. I've had young people say, I just didn't understand why I was running track and I just couldn't do it. And my coach accused me of being lazy. Could that kid run track? Yes. But do they need more? Yes. Dating, like I said, sex education, of course, the NCAA sports mandate And as I've said before, the universal education, which will beget the sickle cell allies, the people like me who have all normal hemoglobin. I am an AA warrior, but I care about sickle cell trait as if all of you are my children. I care about sickle cell as if all of you are my siblings, as if all of you are my parents, or like I said, my children. Sickle cell allies is where it's at, folks. We need people that don't have it to care about it. And that's how we really get to moving the needle. Recently, Black Lives Matter has been a huge hashtag, but I'm telling you, I firmly believe that Black Lives Matter, the needle moved when non-Black lives began to care. If you agree, you agree, but that is the example of the non-affected caring and helping to move the needle toward real change. Here, what is this picture saying? The picture up in the top left, I actually took this picture. This was a field of kids working out. You can see they're engaged in some type of physical activity. And if you could look closely at, which I did, I observed no water fountains. I observed no water, no coolers, no hydration. And these young babies are working out, and this was in Florida heat. But we give water to our pets. We put water in our car. We plant, we water our plants. Why? To avoid the plants dying, to avoid the car running hot, to avoid lethargy in our pets. But in order to avoid dehydration in humans have to be hydrated half their body weight in ounces of water daily. So if you weigh 200 pounds, you should be consuming 100 ounces of water daily to avoid dehydration. When, pre-COVID, when I'm giving this lecture in front of people, I usually ask by a show of hands, based on that calculation, how many of us in this audience are dehydrated? And more times, basically every time, all hands are raised, because we just do not practice proper hydration. And proper hydration is important for all of us, trait, disease, or nothing. But imagine you have this blood condition that requires good blood flow, requires the cells to remain plump, requires the work of what the hydration does to continue good flow in your body. That is the purpose of hydration, and you just have to do it. You have to just take those bottles to the head. And I'm a person that doesn't love water, but I chug it because hydration is important. So here are the protective factors. We went over the risk factors, but the protective factors are, especially when it comes to exertion, to gradually increase from rest to intensity. Gradually increase from rest to intensity. Warm up. If you go into the gym, you start at a slower speed, and maybe you start walking, or you start jogging, but a full-on sprint without warming up, absolutely not recommended. Gradual intensity, gradually increase to intensity, also known as warm up. Hydration, as I said, before, during, and after. By the time you feel thirsty, you're already dehydrated. So that bottle should be, or glass should be coming to your mouth when you open your eyes, and you should be drinking throughout the day. And what do we say? You should start consuming in the morning when you wake up, and by the time you end that night, you should have consumed half your body weight in ounces of water a day. It is a more customizable approach to hydration, as opposed to just telling everyone to drink 8 glasses of water. Some of us need more because we weigh more. Some of us don't need as much because we don't weigh as much. So this is the new school train of thought. And then recovery breaks. Often take a knee, take a break, take a second to breathe. So in other words, warm up, drink up, rest up. parents of young trait warriors that are out there playing soccer, they're out there playing kickball, this is your baby. This is your mantra. Warm up, drink up, rest up. They have to warm up. They can't just go full speed, and certainly not at extended periods of time. They need to hydrate before, during, and after, have their body weight in ounces of water a day, and they need to take recovery breaks. Again, you're welcome to screenshot this. These are the research resources for the adverse health effects that we've discussed today. But we are up against barriers to the literacy. And this is just to give some benefit of the doubt to providers. In the United States, we have confirmed that sickle cell trait is covered the equivalent of 5 minutes in a typical medical school curriculum. So that alone explains why there are so many knowledge gaps there, and basically puts the trait warrior in the position of having to educate their own provider. The stigma we discussed, and even in a household, a sickle cell household where there may be a warrior, a sickle cell disease warrior child or sibling, and a sickle cell trait warrior sibling, there could be guilt or minimization of symptoms because that warrior is suffering so much. Well, I'm here to tell you, there are instances where the trait warrior can suffer as much, if not more, than a disease warrior. Just read Mwape's book and listen to her account of what she's gone through. You heard Agnes tell her story, and we hear a lot of that in trait warriors during pregnancy and what they go through. But if you're told, like the doctors are told, you shouldn't be having anything, you don't have full-blown sickle cell, that minimization can be dangerous. And again, you heard my spiel about the rare designation as it relates to complications. But here are the opportunities. Don't want to just introduce a problem without introducing a solution. Testing, more testing available, more availability of testing in high schools or even earlier. We do have the newborn screening, but by testing, I'm also saying supplemented with comprehensive education. And that should directly affect the surveillance, the data keeping. And that definitely should directly affect the research, the funding that's needed to conduct the research, and then the possibility of developing therapies to address what's happening with sickle cell trait, adverse health effects, pain, crises, and so on. This is just my actual research. My thesis in my PhD program was about the knowledge, perceptions, and beliefs amongst coaches, trainers, student athletes, and their parents at a Florida HBCU. It was very informative and revealing. But again, I said earlier, education is desired. They believe education is needed. And this was, we did quantitative surveys as well as qualitative focus groups with parents, a focus group of parents, a focus group of student athletes, and then a focus group of coaches. Student athletes want the education and they feel like everybody should be tested. They didn't express any threat of stigma from a positive diagnosis. And the bottom line was that care and concern of the non-affected ally is needed to help move the needle. Anyone can be an ally. You don't have to have sickle cell to care about sickle cell. You don't have to have sickle cell trait to care about sickle cell trait. And here's some science there. These letters at the bottom, these are all genotypes. And did you know that the genotype for non-sickle cell, meaning you have no sickle in your blood, you have a normal adult hemoglobin copy from your mom and a normal hemoglobin adult copy from your dad. That is AA. So even allies are AA warriors. It's not a sickle genotype, but it is a genotype. And this is just one resource we put together, a parent's guide to sickle cell trait, because often our parents express, can you just give me something to take with me to show my coach, to show my kids' coach, to show my doctor? So we pulled together this document that you can download and take with you. It needs to be expanded. It's about a year dated now, but it's still something, and we've been thanked a lot for offering this. And here's, how you can keep in touch with us. AsOneFoundation.org is our website. My email is tomia@AsOneFoundation.org, and pretty much all social media at As One Foundation. On Facebook, we are the As One Foundation. And I'm going to stop sharing.
Thank you so much, Dr. Austin. That was amazing, as always. We really truly appreciate you. And like I said, you give me hope whenever I feel like I can't continue, or I'm having a bad day, or I'm in so much pain. And I'm a bit emotional at the moment, but I've kind of gotten over everyone seeing my emotions, because it is what it is. But I truly appreciate you, and I'm inspired by you, and you give me hope that we will be heard as well. So thank you. Our next, would you like questions now, or should we just get everyone to ask questions later?
This is World Sickle Cell Day. So I actually have a number of presentations. So I would not mind to take the questions now, because I might have to exit early.
Okay, no problem. Does anyone have any questions on panel? Because I think I messed up with the Facebook recording. So anyone have any questions to ask Dr. Austin now? Feel free.
And it's absolutely okay if there are no questions now. I checked back for questions in the chat.
Okay, fabulous.
Yeah.
So I'll share this once we've shared our stories, I'll share, and then if anyone has questions, I'll refer them on to you.
Perfect.
Fantastic.
Thank you.
Thank you. And thank you for joining us.
Sure.
And happy World Sickle Cell Day, everyone.
Absolutely, yes. I'm going to stay as long as I can.
Okay, thank you. And when you leave, I'm going to try and join the Jamboree later as well. So.
Oh, good.
Yeah.
Oh, I forgot to mention that. Yeah.
Yeah. Can you give us the quick details of when it's happening?
Well, it's been happening since midnight. We are part of a 24-hour marathon that's powered by the Sickle Cell Community Consortium. But 2 p.m. Eastern time, the As One Foundation, we are putting on the Genotype Jamboree Day Party. It is absolute fun. It's an escape. It's not us zooming in education. It is turn it on, turn it up, and get in your floor and dance. This is just our contribution to bring awareness, but in a different way, give our warriors and trait warriors an opportunity to just let loose and celebrate World Sickle Cell Day as well as Juneteenth.
Wow. Thank you so much.
Sure. Thank you.
I think it's 8 p.m. UK time. I can't remember, but I'll.
Oh, perfect. Good.
I think. So yeah, I'll be there. Thank you.
Okay, good. Thank you. Thanks for allowing me to share that.
You're welcome. Have an amazing day. And when you need to drop off, feel free. That's fine.
Sure. Thank you.
Our next panelist is Leah, all the way from the United States of America as well. And she's going to share her sickle cell trait story with all of us. So feel free, sis. Welcome.
Thank you. I'm honored to be here. I am very written vocally about my experiences with doctors and such. This is my first time speaking out loud, so forgive me if I get emotional. I have not spoke out loud about this. I have written about it constantly because that's my only outlet to let it all go. But my name is Leah Vasquez Ward. I'm a married woman with 8 children. I am a former nuclear power utility worker, crisis support specialist for mental health. I have my undergrad in behavioral health. And right now my focus is on my health, my family, sickle cell disease awareness. I have founded a group for the East Coast and the DMV area on Facebook. And I just try to provide research and information. Sometimes I may share my story there, but many times I share my story through Mr. Dom Ali's board, Sickle Cell Trait Journal. My group is small. I have about 32 people now. I'm trying to grow it, but I have so much on my plate. I have a lot on my plate. I'm trying to take care of 8 children while I am very ill. With that said, I'm going to tell my story, and I'm going to start from here. Throughout my childhood, I would get pains in my knees and my legs. My knees will lock up. Afterwards, at night, after I would eat dinner, in the middle of the night, everybody else would be sleeping. I would get up and have to vomit. Sometimes I would get diarrhea. My mom would take me to the doctor. They would tell my mother, oh, she has gastroenteritis, or she has a stomach bug, or she has growing pains. My mother was never taken seriously, but she gave me a very strict Caribbean diet and carrot juice every day to help me get through those situations. Because she is a Jamaican woman from the Caribbean, so she knew about sickle cell. She tried to tell the doctors, I think my daughter has more than just trait, but my hemoglobin electrophoresis says hemoglobin AS with an elevated hemoglobin A2, so I'm trait. Well, that's to be decided because I'll be getting different information from different doctors. Some doctors think I have beta thalassemia minor as well. I have some weird intron variations that some people say because it's found in India and the Middle East could be beta thalassemia minor, but that's neither here or there. Right now, all I know is that I'm sick and that I always get crises. I'm getting crises more and more and more as I get older. And throughout my pregnancies, I always get high blood pressure at the end. Have to have my babies like a couple weeks early to make sure they come out and not die. But 16 months ago, I had a daughter. And 16 months ago, I had a devastating experience. At about 35 weeks pregnant, I couldn't breathe. I was having crisis. The doctor couldn't figure out what was wrong with me. They did some tests. They said I had cholestasis of pregnancy, fluid in my lungs from asthma, and they didn't know why I was in such widespread pain. They chalked it up, oh, it's just pregnancy pain. They kept me in the hospital to treat my liver and my lungs with steroids. I had to stay in hospital for 37 weeks until she was born on oxygen, steroids, and the liver medication. When she was born, she had to be induced. I had to be induced to deliver her. And when I was induced, I was in crisis. I didn't want the doctors to touch me. I had to be put on pain medication and an epidural to have her, just to have her. And I had 8 children. I've delivered without epidural and pain medication. Even though I had to be delivered early, induction, whatever, I could deliver my babies. But this baby, I could not deliver by myself. I had to have pain medication. With that said, it took me hours to deliver her. My uterus was not functioning. She did not want to come out. I had to have my abdomen pushed down on to drop the baby and to push her out. She had to be evacuated by hand. The doctor literally had to go in there and pull her out. It was traumatizing. With that said, after she was born, within a half an hour, I started to hemorrhage massive, massive blood clots. When my placenta was delivered, I hear the nurses and the doctor say, we've never seen a placenta this big. This is abnormal. My placenta was abnormal. Later on, when the pathology report came back for my placenta, they found sickled cells in my placenta. When they did a sonogram of my uterus to make sure after I hemorrhaged, everything was expelled, I had necrosis of my decidual lining of my uterine cavity. So I had necrosis in my uterus. They thought they took care of all of it. I got stabilized. I had to stay in the hospital 2 extra days because my blood pressure was slow to come up. But after I was stabilized, my bleeding slowed. They discharged me back home. All that month, I had reoccurring pain crisis after my daughter was home, and I had my newborn baby, where my oldest daughter had to basically care for her because I couldn't even care for my child. I was in crisis the whole month long. And it wasn't just normal postpartum aches and pains. I was debilitated. I could not get up out of bed. Exactly 1 month later, on March 29th of 2020, I started to hemorrhage massively again. My husband put me in the car and drove 120 miles an hour to the local hospital. In the local hospital, the clot sizes were that of like a 20-week-old fetus. They were huge. I was passing golf ball and then fist size, and then even bigger than that, clots. They stabilized me enough to send me to my OB/GYN, which was an hour away from that hospital. I had to have another D&C. At that point, they didn't transfuse me. I don't know why. My red blood cell count was 2.3. They did not transfuse me. They gave me fluids and TA. The doctor knows what I'm talking about. It's a medicine to help build your bloods. After that, they kept me in the hospital for about 3 days because of COVID-19, and they rushed me out of there in a quick and in a hurry. Well, you're stable enough to go home. But at that point, my whole body was wrecked. Currently, I have enlarged liver, I have kidney problems, I have proteinuria, hematuria, ongoing chronic UTI, hematuria, proteinuria without UTI. Come to find out this past week that they've been hiding pelvic bone deformities that I didn't have before, like arthritis, sclerosis, stuff like that. I've had CAT scans done over and over and over again, and they did not tell me about this thing until the last time I was in the emergency room. Apparently, when they did the CAT scan last time, they didn't put it on the report, and I'm just finding out that I have sclerosis of my pubic bone. I'm still suffering. I'm still in pain. I have crisis monthly now, but my chronic pain in my hip and my lower abdomen and my tailbone never goes away. I'm trying to make this brief because it's hard for me to talk about this, but all my life, I've had pain. All my life, I've dealt with it and just ignored it. I never told anybody about it except for my mother. I ate a very good Caribbean diet, so my crises didn't last long. They were seasonally, but now life has become unmanageable. I can't get doctors to listen to me. They want to treat a diagnosis. They don't want to treat me. I'm being shipped off specialist to specialist to specialist to specialist. Each doctor is passing the buck because I have so many comorbid conditions. While I sit here and suffer, they want to treat a diagnosis. They don't want to treat me. That about sums it up. I have more details written down, but I'm kind of angry right now. So I don't really want to say too much more. I'm going to keep my time short and brief. But I also am not feeling well because I'm suffering from UTI, and I'm in pain as I sit here, and you probably see my phone shaking a little bit. I'm unsteady. So I'm gonna come off a camera. Y'all can discuss, talk, ask me any questions you want, and I will further elaborate for you. But as far as sharing any more of that experience, I'm just not ready. This has been hard. So I'm coming off a camera because I'm going to cry.
Thank you so much, sis, for sharing your story. Thank you for allowing yourself to be here and be vulnerable and allowing your voice to be heard. And I can hear your pain. I can feel it. I empathize with you through my experience as well. And I'm sure the many who will hear this as well will also be able to relate in some way with sickle cell trait, the unheard voices, and hopefully encourages them that they're not alone and there is a support network here for them. So thank you so much for sharing. Our next panelist today is Dr. Rob Sokolic. He is, okay, so he's a board certified internal medicine medical doctor. He also is board certified in hematology, medical oncology with over 25 years experience in clinical medicine and research. His clinical interests are in cell and gene therapy for benign and malignant disorders of bone marrow. And he was also the lead physician for the Sickle Cell Disease Multidisciplinary Clinic at the Lifespan Cancer Institute. So welcome, Dr. Sokolic. Oh, you're on mute.
I'm sorry. Thank you for that introduction. So my plan was to talk about advice for patients who have symptoms who have been diagnosed with sickle trait. Now I can try to share my screen, Mwape, or did you have, I think I sent you my presentation, but let me see if I can share it. That's not working. Do you have my presentation you can put up?
Sorry, I do, yes. Bear with me just a moment. Screen share.
Meanwhile, see if I can get mine up.
Can you see it?
Yeah, there it is. So if you could just put that on presentation mode. It's on the low, yeah. Yeah, do that one.
Cool. Not sure.
Okay, if you go down to the bottom of the window, on the right-hand side, yeah, two icons to the right.
Which one am I clicking?
Okay, that's good. That's good.
Okay.
Yeah. Okay. All right. Okay. All right. So my name is Rob Sokolic. I am a sickle cell disease advocate and educator. I practiced hematology for, as Mwape said, about 25 years, and most recently ran a sickle cell clinic in Rhode Island Hospital. As part of that clinic, I tried hard to encourage my patients, to advocate my patients, and to work with my patients to improve their lives. I have had some patients with sickle trait, and I've sort of developed an approach to treating them, which is not science-based, not evidence-based that much, because the evidence is very slim. But you know, this isn't unusual. It's not unusual in medicine. There's a lot of stuff we don't know, and we have to have an approach. And every doctor does have an approach for what happens when you don't know what's going on. And I've adapted that approach to patients with sickle trait. So next slide, please.
Okay.
Thank you. So actually, excuse me just a minute, I'm sorry. Had to yell at my kids, I'm sorry. So I'm going to talk a little bit about the biology, and it's more extensive than I normally do, but the reason I'm doing that is I think that for patients with sickle trait, and truthfully, any patient should understand the biology of his or her disease.
Mhm.
But for areas where the terminology is confusing, the med school education isn't great, it's important that we all be on the same page and understand what's actually going on, at least what we understand is going on at this time. So I'm going to start out. So sickle cell disease, this is from my regular presentation on sickle cell disease. So the problem in sickle cell disease is that sickled red cells are rigid. The rigid cells break and become sticky when they try to flow through the small blood vessels. These cells, the red cells, platelets, and white cells form clots in the small blood vessels, and these clots lead to the symptoms of sickle cell disease. It's more involved in that, but that's the basic idea. And this is relevant for people with sickle trait as well. Next slide, please. Okay, thank you, Mark. So sickle cell disease is a problem with hemoglobin. And again, I've written this really the way I talk to patients who haven't heard about sickle cell disease before. So if I'm repeating stuff you guys know, let me know. But sickle cell disease is a problem with hemoglobin. Hemoglobin is a molecule in red blood cells that brings oxygen to the body. So hemoglobin is made of two parts, heme and globin. There are two types of globin in each hemoglobin molecule. There's alpha globin and there's beta globin. The problem in sickle cell disease is with beta globin. And this becomes important when you talk about confirming the diagnosis. Next slide, please. And so, I'm sorry, but this is a picture of a hemoglobin molecule. So the alpha and beta globin genes are those long gray strips, and the heme is what looks like a flower there. Yeah, the yellow with the red inside is the iron molecule. So these are the different parts of a hemoglobin molecule. And again, the reason I'm stressing this is so people can understand what's actually going on in order to understand why there can be diagnostic confusion. Next slide, please. So there are many disorders of hemoglobin. So there are disorders of heme, like porphyria, and there are disorders of globin. Sickle cell anemia is a well-known disorder of globin, as is thalassemia. There are many others, C, D, E, Harlem, Punjab. They tend to get named now after the town where the patient lives when they're first discovered. And there are many more. Next slide, please. So as Dr. Austin was saying, everybody has two beta globin genes. You get one gene from each parent. People who don't have a hemoglobin disorder have two genes for beta globin A. So they're called AA. People with sickle cell anemia have two S genes, and it's called SS. People with sickle trait have one A gene and one S gene, and that's called AS. And you guys have heard this before. Is there any question about this stuff?
Not from me.
Okay, excellent. So next slide, please.
Okay.
So this is an example of similar thing with hemoglobin C. Hemoglobin C disease is a different disorder of hemoglobin. It's not sickle cell disease. It has its own natural history, its own way of presentation, and the treatments are rather similar. But so again, people who don't have a hemoglobin disorder, AA, people with hemoglobin C have 2 hemoglobin C genes, they're CC. People who have hemoglobin C trait are AC, just like people with sickle trait or AS. People where they get one sickle disease, one sickle gene and one hemoglobin C disease have a separate disease that's called sickle hemoglobin C disease. Their genotype is CS. This is not the same as having sickle trait and having hemoglobin C trait. This is a separate disease, and it's quite more severe than hemoglobin C trait. Next, which is usually not very symptomatic. And I know you've heard that about AS, but it's more the case for AC. Next slide, please. So people with hemoglobin with one C and one S have CS. Now, this is what I just said. They do not have sickle trait and hemoglobin C trait. They have a separate type of sickle cell disease, which is called sickle hemoglobin C. These people are said to have compound heterozygosity. Again, it's a lot of syllables, but the point is heterozygous, someone who's homozygous has 2 genes the same, like an SS, heterozygous, 2 different ones, like an AS or a CS. If you have 2 genes for 2 different beta globin disorders, so you're heterozygous for both, but you're compound heterozygous. Next slide, please. So similarly, and this is important, if you have a beta thalassemia gene, then you have sickle beta thalassemia. This is not sickle trait and thalassemia trait. I've seen patients diagnosed with that. That diagnosis is incorrect. So the disease is called sickle beta thalassemia. It's a separate disease. Some cases of sickle beta thalassemia are as severe as SS. And again, compound heterozygosity, just like for sickle hemoglobin C. It gets a little bit more complicated because thalassemia is a different kind of hemoglobin disorder than sickle cell disease. But we can talk about that more if people like. Next slide, please. So a problem that I see very often is people whose hemoglobin disorder is not properly diagnosed. So if you're compound heterozygous, one S and one other globin that's not globin A, they may be told they have sickle trait, or they may be told they have sickle trait and thalassemia trait, or sickle trait and C trait. This is wrong. This is not sickle cell trait. This is not 2 separate genetic traits. This is a compound heterozygous sickle cell disorder, like sickle hemoglobin C or sickle beta thalassemia. Next slide, please. And so people with compound disorders have a range of severity. Some are severe and some are not severe. Some only seem severe in adult life. I had a fair number of patients with sickle hemoglobin C. They really weren't ill as children. And, unfortunately, most of the research on sickle cell disease is in children. And so from a pediatrician's perspective, these kids aren't sick. But as they become adults, they get sick. And so it's important to recognize that. Next slide, please. So, I want to be respectful of my colleagues. So doctors who are not a hematologist may not have a sophisticated understanding of how to diagnose hemoglobin disorders. I am a hematologist. I don't have a sophisticated understanding of diabetes. Okay, I sort of know about diabetes. There's 15 new drugs since I was in med school, and I don't know how to use them. I defer to my colleagues. So people, doctors who are not hematologists, don't have the same understanding of sickle cell diagnosis as doctors who are hematologists. If you're told you have a hemoglobin disorder, I always advise people that that should be confirmed by a doctor who's familiar with hemoglobin disorders. And that's not rare. You know, cardiac disease, we have confirmed by doctors who know about heart disease. Asthma, we have confirmed by doctors who know about asthma. Doesn't have to be a hematologist. I can teach a physician about how to diagnose hemoglobin disorders in half an hour. As a matter of fact, that's how long it took me to learn it. Well, it took me a little longer. But often it is a hematologist, but not necessarily. The important thing is that you see a doctor who understands the disorders. This is very important, especially if the patient is having symptoms that are not what were expected when they've been given their diagnosis. Mm-hmm. So if you're told, yeah, you have sickle trait, you shouldn't be symptomatic, but you have avascular necrosis and you're in pain every day and you got renal medullary carcinoma, it's appropriate to reevaluate the diagnosis and make sure the diagnosis is made by somebody who understands the disorders. Next slide, please. I'm sorry.
Bear with me. Yeah.
So that's the biology. And I'm sorry if it was a little heavy on that. Are there any questions about that before I go on?
Not from me. In fact, no, I did have.
I do have a question. I have a question.
Yeah.
Okay.
I have a slightly, well, my hemoglobin A2 is always over 4%. However, right. Hematologists tell me because I have normal hemoglobin above 56%, I'm not supposed to have symptoms. I have been to 2 different hematologists. One says I'm S trait. One says I have sickling disorder because of beta thal trait and S trait. I have been misdiagnosed and switched all around, and I don't know what's going on, but could it be possible that I have more than just sickle cell trait?
Yeah, so 4% is sort of a cutoff that we use for diagnosing thalassaemic disorders. So somebody who has one sickle gene and who has hemoglobin A, but who has hemoglobin A2 above 4%, the formal name for that condition is sickle beta plus thalassemia. And some patients with sickle beta plus thalassemia are not symptomatic, but some are. So I would encourage you, Ms. Vasquez-Ward, to see a physician who is skilled in the diagnosis of hemoglobin disorders. Because on the face of it, what I would say is, you know, that hemoglobin electrophoresis is not sickle trait and thalassemia trait. It's sickle beta plus thalassemia.
Thank you.
You're welcome. And we can talk more offline if you like. I can give you some references. Are there any other questions?
I was just wondering, Dr. Rob, could it be possible to hemoglobin F or fetal hemoglobin being a lot higher in childhood as to why some present later on?
It could be. You know, I have to say that generally, so in people who are AA, hemoglobin F disappears in the first 6 months. People who have persistent fetal hemoglobin, it tends to be at a persistent level after those first 6 months. It doesn't tend to go down in older age, although the truth of the matter is that's my understanding. I don't know that that's well researched, and I certainly don't have more detailed understanding of that. In any case, if a patient has fetal hemoglobin who's more than 6 months old, then that patient's hemoglobin is not like most people. And as a hematologist, I would want to understand what's going on with that patient. So, you know, the other thing to know, sickle cell disease, all forms of sickle cell disease are progressive diseases. So damage that you get early in life stays with you and you get more as you go on. And that way it's very similar to diabetes or to hypertension. So, you know, regardless of what levels of hemoglobin F are, I would expect a patient with any form of sickle cell disease who's not well treated to accumulate adverse outcomes as he or she ages.
Okay. And as in within and I think on another presentation I'd heard you mention that sickle cell trait should be included within the sickle cell bracket. Would you say that?
I classify sickle trait as a type of sickle cell disease.
Okay.
Now I didn't make that up, but there is, you know, I got that from review articles, but there is disagreement on that.
Yeah.
For an individual patient, it doesn't necessarily matter that much. What matters for an individual patient is the patient has symptoms. Are the symptoms being treated? Do the symptoms indicate something that you can prognosticate, that you can tell what's going to happen in the future? Whether we call AS sickle cell disease or not is important, certainly with the stuff Dr. Austin researches. It's important in terms of funding. It's important in terms of research. It's important in terms of understanding one's identity.
Yeah.
But it doesn't affect medical decisions, what we call it. And, you know, as an example, when I started medical school, we diagnosed leukemia for anyone who had more than 30% leukemic cells. About 5 or 10 years into my career, we changed that to 20%. And we changed that by a bunch of guys sitting around and voting. It's not the case that a whole bunch of people with 25% leukemic cells suddenly developed leukemia. It's that we understood it better, so we changed the name. And that's the case with sickle trait too. We can all agree on what the genotype is. We can all agree on what the symptoms are. How we classify it for purposes of research is an important research question, but doesn't affect how you treat a patient.
Thank you.
So any other questions before I go on?
Does anyone else got questions? No.
Okay,
Are
great.
they? Can I add your or I can circulate your email within the after the discussion is finished, can't I? Is that okay for anyone to contact you with any questions? Or
Let's talk about that offline.
okay, no problem. So continue the screen
Yeah, if you
share.
can put the presentation back up and walk it.
Okay, no problem. Thank you. I think it was this one. Yeah.
Yeah. Okay, so I have a couple of, the way that I organize how I talk to people with sickle trait is there are a few questions that they should ask. So the first question is it really sickle trait? If the symptoms don't match the diagnosis, it's important to readdress the diagnosis. Again, that's true throughout medicine. And as Dr. Austin said, it's not hard to diagnose hemoglobin disorders and it's not expensive. So, you know, being a cancer doctor, I can't tell you how many useless lab tests I see, how many useless lab tests I order. But, you know, adding another hemoglobin electrophoresis, particularly if the test is not available. If someone comes and says, yeah, I was told 15 years ago I have sickle trait, but I don't have the paperwork, it should be ordered again. You don't, actually, this is something I learned from one of my mentors. It's not that you don't trust the patient, it's that you don't trust that the data was communicated accurately and in a way that the patient understands. So it's always good to repeat it. So that's the first question. Next slide, please. And so it might be sickle hemoglobin C, it might be sickle beta plus thalassemia, that's the most common error. It might be something unusual. And so it's important to get a real accurate molecular diagnosis. On the other hand, sometimes it is sickle trait. I see a patient, I say, hey, this doesn't sound like sickle trait. And, let's reconfirm. And I reconfirm, and they've got 15% S and 84% A and 1% A2. That's sickle trait. It's not the only thing that can go wrong with red blood cells. So there may be another blood disorder. So I've listed here some of the common ones: pyruvate kinase deficiency, G6PD deficiency, hereditary spherocytosis. These disorders tend to occur in the same ethnic groups that have sickle cell disease, where sickle cell disease is more frequent. As Dr. Austin said, anybody can have sickle cell disease. It's more frequent in certain ethnic groups. And there's good biology that explains why that's the case. But if you have sickle trait and you have G6PD deficiency, then your disease may be worse. For example, Agnes said earlier that her eyes were yellow when she was very sick. So she's hemolyzing. I don't care what her genotype is. She has a hemolytic anemia, and maybe there's something else, or maybe there's not. But again, these are one-time tests. They're easy to do. And actually the cheapest test and one of the best tests is to look at the blood under the microscope. So anyone who carries a diagnosis of a sickling disorder, the physician should have looked at the blood under the microscope. If that's not done, that's skipping steps. And so, again, the truth of the matter is most doctors or hematologists aren't set up in their office to do that, to look under the microscope. So when I have a patient needs a procedure I'm not set up to do, I refer the patient. And that's just routine for any kind of anemia. You look in the hematology textbooks, that don't say that. You have to look at the blood. Next slide, please. So this was a study from the Nigerian Postgraduate Medical Journal in 2019. This is of great concern in Nigeria. Patients with sickle cell disease, 28% had G6PD deficiency. It's important to know that G6PD deficiency is another hemoglobin. It's not hemoglobin disorder, it's an enzymopathy, but it causes problems with hemoglobin. So it's another red blood cell disorder. There are certain dietary restrictions. There are certain restrictions on what drugs you can use. Every physician knows about G6PD deficiency. We all learn about it in med school. And again, we learn it's rare. You're probably never going to see it. But if you do see it, you have to check the drugs. And there's databases where you check which drugs. So one thing that can happen if you have G6PD deficiency and sickle trait, you're doing fine. You get a drug you shouldn't get. Now you have sickle crisis. And next slide, please. That's just an example of G6PD. Now, on the other hand, sometimes the genetics say sickle trait. There's no other blood disease that we can identify. There may be one that's not known, but we can't find one. And so we say, but the patient has symptoms. So maybe the patient's symptoms are really due to sickle cell disease, to sickle cell trait. And there are different possibilities. So one possibility is rare or complicated genetics. They might have a disorder of hemoglobin, of alpha globin. They may have one sickle cell gene, one globin gene is S and one is not S, but has another mutation and an intron down the line, and it gets confusing. That needs to be looked at. Those tests are a little more expensive, but it's in the United States anyway, it's insurance companies' money, which I don't mind spending, and it's cheaper than an MRI. There are labs you can send the blood to look for rare or complicated genetics. It may be that it's just something we don't understand. So, we've known about sickle cell disease for 100 years. Sickle cell disease is thousands or millions of years old. Well, maybe not millions, thousands of years old. So there's new stuff all the time. There's more known about sickle trait and about sickle cell disease than when I started in medicine, and I'm not all that old. It may be something completely different. We always have to consider in medicine, we know that we don't understand everything because we're all, we got journals coming out every month explaining to us stuff we didn't understand. So that's always important to consider. What I do in that situation is I start looking for signs of sickle cell disease. Next slide, please. So there are some signs of sickle cell disease that are not consistent with sickle trait. So having Howell-Jolly bodies. Now, again, that sounds a little esoteric. It's something you see pretty easily when you look under the microscope, but most physicians aren't set up to look under a microscope. But whenever you order a CBC, if it's abnormal, a technician looks at it and the Howell-Jolly bodies are easy to spot. And it comes back on the report. It says hemoglobin is this, white cells are this, patient also has Howell-Jolly bodies. So someone who doesn't have a spleen has Howell-Jolly bodies. There's something more going on besides just sickle trait. AVN, not something you see in sickle trait. If the patient has sickle trait and has AVN, you need to readdress the diagnosis. Pulmonary hypertension, an enlarged heart, H-shaped vertebrae, very classic, typical finding that you can see on the chest x-ray. So if patients have had a lot of pneumonias, now not everybody necessarily looks at the bones when they're trying to diagnose lung disease, but the data is there. And, once you know to look for it, it's easy to go back and look for it. Frontal bossing, scalloped ribs, a low haptoglobin. So this is a blood test that's always low when people are having red cell breakdown. Elevated serum-free hemoglobin. That's a test that most people who aren't hematologists don't order because it's a little confusing, but it's not normal. And if it's elevated, then it's telling you there's some hemolysis. There's lots of other things you can look for. I actually ran out of room on the slide before I ran out of stuff to write. So next slide, please. So this is a chest x-ray with H-shaped vertebrae. And so I'm sorry, I don't have control here. So you see, and if you move just over a little bit to the right, Mwape, there's the spine. And so each of those bones there, which are the lighter areas, is a vertebra. And if you can see, if you go down, Mwape, go down, right there. Right, so you see that this vertebra is, they say H-shaped, it's also called fish mouth. The space between vertebrae is wider in the center than it is at the sides. So that's a sign. It can be other things too, but one thing it can be is sickle cell disease. Most commonly, it's sickle cell disease. If you have a patient with sickle trait and the patient has pain, it may be related, it may not be related. The patient may or may not have pain. You don't know, it's hard to tell. Patients don't change the shape of their vertebrae so that they get sympathy. That's something objective. Next slide, please. So there are signs, as Dr. Austin said, of sickle cell disease that are consistent with sickle trait. So dilute urine is one of them. Disorders of the retina happen as much with people with sickle trait as with any other kind of sickle cell disease. What this means is that patients with sickle trait should have an eye exam once a year and should have a urinalysis once a year. If they can't concentrate their urine, that's important to know because it increases the risk of dehydration. And Dr. Austin spoke, quite a bit about what happens when you get dehydrated and you have sickle trait. There are others too, as Dr. Austin said, there are rare cases of renal medullary carcinoma in patients with sickle cell anemia is rare. So it's even more rare in sickle trait, but it can happen. Next slide, please. Once I see, I'm sorry, Marpa, could you go back one slide before I get to that? So I do this search for signs of sickle cell disease. So I do some blood tests, I do urine tests, I do an echocardiogram to look for pulmonary hypertension. That's a little expensive, but it's non-invasive. It doesn't hurt the patient. It's not all that expensive. If a patient has pain in one part of the body, I get an MRI. And I saw in the conversation here, someone said that they don't do MRIs of arms. That's not true. You can do an MRI of any part of the body. MRIs are expensive, but very many MRIs get ordered for very bad reasons. If somebody's staying home out of work, needing narcotics, that's a reason to investigate. And it's well worth the MRI because it's less expensive than a night in the hospital or an ER visit. Next slide, please. But, you know, again, sometimes the genetics are AS. There's no signs that are inconsistent with sickle trait. There's no other hematologic disease, and the patient is still symptomatic. So this is something my mother told me. My mother's a family physician. So she said, listen to the patient, Rob. They usually tell you what's wrong. And actually, this conversation was in the setting of a patient not with sickle trait, but with Wiskott-Aldrich syndrome, which is another rare disease. The patient had been in the hospital for 3 weeks telling the doctor, I think this is my Wiskott-Aldrich syndrome. And the doctor kept saying no. Eventually, the patient went to surgery and it was the Wiskott-Aldrich syndrome. And, you know, that doctor felt badly and was embarrassed and hadn't helped her patient. So if a patient comes with a hypothesis about what's causing a disease, I check. And, you know, even if it doesn't seem that likely to me, if it's unlikely, I'm going to look pretty stupid that the patient told me the answer and I didn't check. So, you know, sending an electrophoresis, that's fine. Reconfirm the diagnosis. If the patient tells me that her pain is caused by the phases of the moon, you know, I can't check that. It might be true, but, you know, I don't dismiss what the patient says is the cause of the disease. Maybe it's evil spirits. You know, there are a lot of different theories of what causes disease, and we don't know always, but, you know, I check what I know about, and I look for, you know, sometimes you get surprised and the patient does know is correct. But then, you know, often, you know, once you check, you find nothing you can hang your hat on. So then the question is, are there other causes of the symptoms besides sickle cell disease? Next slide, please. So some of the common symptoms of sickle cell disease are fatigue, pain, shortness of breath. These are symptoms that are very common in primary care. Many, many diseases cause these symptoms. So a person with sickle trait, if God prevented the sickle trait from ever hurting the person, could still end up with shortness of breath. And it could be asthma, it could be heart failure, it could be whatever else. It still needs to be treated. And so it needs to be investigated. Next slide, please. So the question is, why am I looking for other causes of these symptoms when the patient is telling me it's because of sickle trait? I just said, listen to the patient. So you always have to look for other signs of symptoms. In patients who I know have sickle cell anemia, that I've done the genetics, they come in with pain, I always look for other causes of the symptoms. And the reason for that is because sickle cell anemia is very difficult to treat. The treatments don't work so well. They have important toxicities. I'm looking for something else that I could treat that might be easier to treat, easier for me, but easier for the patient. If I have a patient with rheumatoid arthritis, for example, doesn't know she has rheumatoid arthritis, comes in and says, I have pain. I'm like, it's because of my sickle trait. And I'm like, okay, you know, people with pain with sickle cell disease, you treat with narcotics. If I miss the diagnosis of RA and I put the patient on narcotics, I haven't helped that patient. I've listened to the patient. I've trusted what the patient says, but I've actually harmed the patient. So looking for other causes doesn't mean we're not listening. It doesn't mean we're not taking you seriously. It means we are taking you seriously, but we're trying to find the best way to help. And so, you know, a lot of times people say, well, the doctor doesn't believe I have my symptoms are because of sickle trait. And that's true. You know, so I had a guy in my clinic with sickle trait, and I didn't believe his symptoms were because of sickle trait. And I kept looking for other causes, and I didn't find any other causes. I still treated him. I had him, you know, in my clinic for 2 years. Ultimately, he passed away from sudden cardiac death. But you know, it's not that I didn't trust him, it's that I didn't want to use the treatments for sickle cell disease because they can be harmful. So next slide, please. So sometimes I don't find a cause of the symptoms. Very common in primary care. Well known, there are papers written about it. And every physician has an approach to how you treat patients whose symptoms you can't explain. Now, what some physicians do is they tell the patient, you're not sick, don't come back. So that is one approach. A lot of patients aren't satisfied with that approach. If you're not satisfied with that approach, then you know, maybe you find a physician with a different approach. So my own approach, I treat the symptoms. I have regular follow-up. So if a patient comes in and says, I have this pain in my hip for 3 years, I don't understand what's going on, I'll treat the pain in the hip. You know, I'll do the appropriate investigations, I'll treat the pain. And then I say, come back in 3 months. I don't say, if it's not better, come back in 3 months. I say, come back in 3 months or come back in a month. And you continue to follow. You scheduled to see the patient regularly so that the patient, first of all, you get a better sense of what's going on with the patient when the patient is not symptomatic, at least it's complementary. And second of all, the patient knows that the patient will be seen and attended to and doesn't have to have symptoms to be seen. So I get appropriate consults. So even if I think I know what's going on, I think I've done the thorough musculoskeletal exam, but the patient still has hip pain, I send them to ortho. And, you know, again, there's lots of consults. Being a consultant, I've seen plenty of consults that didn't need to be seen by a hematologist. But, you know, you don't know what's going on, you ask somebody else. Basic rules of medicine. Do screening, follow up any abnormals. So if I find somebody with a hemoglobin of 10.6 who's feeling fine, and I got the CBC because the patient was going to have a bunion removed, I might say, okay, no, don't worry about it. But if I have a patient with fatigue with a hemoglobin of 10.6, you know, I say, well, look, you know, this could be because of anemia, and so I'd better follow this up. The other thing to do is to optimize treatment of known disorders. So a patient comes in to me, as a matter of fact, my patient I saw with sickle trait that could never figure out what was going on had diabetes, and his diabetes wasn't well managed. I just said earlier in the talk, I don't manage diabetes, and I don't, but I got him hooked up with a primary care physician to manage his diabetes. Because if the diabetes isn't well controlled, then that can cause symptoms, and the diabetes needs to be well controlled, whether or not it has anything to do with what I'm seeing the patients for. So you optimize the treatment of what you know is there, and then recommendations for diet, for exercise, for mental health care. You know, I have to say, as a specialist, this also isn't my forte, but that's why I recommend that the patient have a primary care physician. And these are things that primary care doctors know better than I do. They know how to do well, and they should be done. It doesn't mean that I'm not going to keep seeing the patient, but just like the primary care physician is sending the patient to me to look at the hemoglobin, I'm deferring to the primary care physician to recommend diet, because it's not something I do that well. But I continue to see the patient. Now, some of my patients didn't have primary care physicians, and I would do some of that work. And, you know, I told them, look, you know, I'm doing the best I can. I'm not a primary care physician. You should have one. And, you know, some would and some wouldn't. If they wouldn't, then I did the best I could for it. Next slide, please. So then the question comes up, why don't we just treat for sickle cell disease anyway? The patient's saying, I have sickle cell disease. There are known treatment, or my symptoms are caused by sickle cell disease. There are known treatments for sickle cell disease. Why don't you give me the treatments for sickle cell disease? these treatments have adverse side effects, and these aren't, penicillin gives you diarrhea, that's a problem. But, a lot of people prescribe penicillin in case someone might have an infection. You give it for 10 days, the patient may have a side effect, but the patient may get better, you might have helped. Treatment for sickle cell disease is lifelong. Treatments for sickle cell disease have adverse effects. Hydrea lowers your white count. Narcotics can give you narcotic use disorder. Stem cell transplant can kill you. Even the new medicines, Adakveo, can cause infusion reactions. Oxbryta can cause fever. Transfusion. So if somebody has a hemoglobin of 10.6, why don't I transfuse them up to 15? That's fine once in a while. You keep doing that, you get infections, you get alloimmunization, you get iron overload. So chronic transfusion becomes a problem. There is also a blood shortage that's been there since I've been a physician. But, if I want to give my patient a transfusion, I do my best to do that. Sometimes I just can't. If I have a patient with hemoglobin of 12, the blood bank won't release the blood. That's a talk for another time. Endari, which is glutamine, tastes bad, causes nausea. 12% of patients, it causes pain. Now, again, Endari might be something that really you could use for someone with sickle trait. And that's an appropriate area of investigation, but it's not known to be safe right now. And again, it would be difficult getting it paid for. What I might do in that situation is advise a patient to buy over-the-counter glutamine powder, which is exactly the same thing. Next slide, please. So again, this is what you do when a patient has symptomatic sickle trait. I've done all the workup. I can't find anything else. You don't tell the patient's not sick. The patient has symptoms. You treat the symptoms, you follow up, you keep doing it over and over again. And, a lot of my patients will ask me, they'll say, well, what do you keep testing the same stuff for? Things change. And maybe, you're only anemic when you're having a crisis. And when I saw you the first time, you weren't having a crisis, but then you are. And so now your haptoglobin is 0. That tells me something important. While I'm doing that, the same as always, screen and follow up abnormals, optimize the treatment known disorders, diet, exercise, mental health, don't smoke, healthy weight, primary care. And really at this point, I would say you got to see a primary care physician, and I would work with the primary care physician. So the question is always going to be there, is it related to hemoglobin disorder? And that's for me to decide. That's for me to think about. But if I can't really show that's causing the problem, I still want the patient's symptoms to be treated. And so I would want to work with the primary care physician. And you keep an open mind, for both the patient and the physician. You keep thinking, well, maybe there's something I don't know. Maybe there's something that's not coming out yet. Rheumatologic diseases cause pain and fatigue. They can take years to diagnose them, and needs a smarter doctor than me. So, if you don't understand, you keep seeing, and maybe you'll learn to understand. Next slide, please. So to summarize, 4 questions that you should ask if you're told that you have sickle trait and you have symptoms that aren't classic for sickle trait. So is it really sickle trait? If it is really sickle trait, is there another blood disease? Is there something unusual, an unusual type of sickle genetics? Is there another explanation for the symptoms? And I didn't put it here, but if there is no explanation for the symptoms, can we treat the symptoms? And so I would encourage any person with sickle trait who's been told that he or she has sickle trait and is symptomatic to ask these questions. That doesn't mean that I don't believe that sickle trait can be symptomatic. It can be symptomatic. We know it can be symptomatic. The research isn't done. That doesn't mean we know that the research wouldn't show anything. It means it's not done. And so you keep an open mind about that. But practically, I'm not going to send a patient with trait for stem cell transplant. It's the risks are too high, and I don't know that it's going to be helpful. So, but you do what you can to treat the patient, excuse me. I'm sorry. Next slide, please. It's probably a signal I should stop talking soon. I think I'm almost done. Next slide, please.
Thank you.
So just like my mom said, listen to the patient, Rob, they tell you what's wrong. So when I deal with patients, we each have our job. I know how to examine people. I know how to order tests. I know how to interpret findings. I know how to prescribe medicines. I don't know how the patient feels. The patient knows how the patient feels. The patient doesn't know how to examine or how to order tests. So patients can learn these things, but they don't have that. If the patient says to me, well, you know, I think that the lab test shows this and it doesn't show this, that's my area. I say the patient isn't the person who can answer this question. But then if the patient says, I have pain in my hip, I can't say you don't have pain in your hip, because that's not my job in the doctor-patient relationship. So you work together. The patients tell the story, the doctor comes up with the explanation. If the patient has an explanatory theory, it should be investigated. But the doctor can't tell the patient how the patient's feeling. That doesn't work. So best results come when patients and doctors work together and form a plan that they can agree on to improve health. Next slide, please. And that's it. So this is what we hope is the future of sickle cell disease. These are all patients with sickle cell disease. Miles Davis, Tiki Barber, who played for the New York Giants. In the upper right is T-Bose from TLC, has sickle cell disease. In the middle is a young girl, Kennedy Burgess, who's a sickle cell warrior now. In the lower right is Dr. Tadilope Fasipe, who is a sickle cell researcher at MD Anderson, who has sickle cell anemia. And so this is what we hope is going to be the future of sickle cell disease. Next slide, please. And that's it. So it was in fact time for me to stop talking. I'd be happy to take any questions. Thanks for your time.
Thank you so much, Dr. Rob. That was fantastic. Does anyone have any other questions? I have just a small sort of query. Just like I normally suffer with a lot of shortness of breath, even while talking. I've noticed, I mean, I used to be a keen runner, and I had complications with exercise. But I'm now measuring my SpO2 levels, so my oxygen levels, both in my sleep, and my levels are, I was told that anything below 95 is quite low. However, it's in my sleep, it's between 80 to 89 on average. And when I'm awake, it's between 90 to 93 on average.
So that's low.
Okay.
That's not normal. It's not to the point where, I mean, 80 is the point where you would need supplemental oxygen.
Okay.
90, not so, but it's not normal. There should be an explanation. One very common disorder that causes low oxygen at night is sleep apnea. And so, you know, often if a patient comes to me and says, well, you know, if I have that kind of data, I might say, well, we better get a sleep study. Sleep studies, they are expensive and insurance companies don't like paying for them, but, you know, you just yell at the insurance company, you get it done. And so certainly for anybody who has lower oxygen saturation at night, it would be important to think of that. And it would be important to treat, because one of the things that causes sickling is low oxygen.
Yeah.
So somebody with sickle trait who has, that's why when you go to Denver, you get in trouble, because the partial pressure of oxygen is lower up there. So someone with sickle trait who's desaturating at night might become symptomatic at night. And that shouldn't be treated with hydrea. That should be treated with the CPAP machine, which works much better. And so that's what I typically recommend for those patients.
Okay.
There's a classic body habitus that goes with sleep apnea.
Mhm.
Usually people who are heavy are more likely to get sleep apnea, but
Yeah.
it happens in people who aren't heavy, or also it happens in people who are light. There are a number of different reasons. There's also central sleep apnea, which doesn't have anything to do with the way your body looks. And so that can be diagnosed with a sleep study. And again, I've sent a lot of patients for sleep studies, and the diagnosis comes back snoring. Okay. But I rolled something out, and lots of sleep studies gotten for very thin reasons. If you go to your doctor and say, I'm tired all the time, you can get a sleep study. So that should be done.
Okay. Because I'm sort of monitoring I've kind of been put on a new health program, and it's catered for sickle cell anemia. So, and this is something that I'm kind of pushing to encourage symptomatic trait patients onto. It's something to do with a company called 11 Health, and they're gathering data to provide evidence to primary care physicians and GP surgeries, so that at least when we present, there's evidence. So I exercised on Thursday for the first time, a bit more moderately than sort of just mild. And I did take big precautions. I was scared because last year, the prolonged crisis that I had triggered off, it was triggered by exercise and fatigue. And so I noticed this Thursday that after the exercise, a couple of hours later, I had to put in preventative measures and just continue hydrating. I'm normally very well hydrated. And my theory, I guess, was I could feel that a crisis was coming on because of the exercise and following that. And that was the night that I ended up having lower oxygen levels, which were between 80 and 89. I can't remember the exact level. I think it was between 80 and 83, actually.
Right. So something else was going on.
Okay.
And
so that could have been the cause.
Yeah, I think that certainly. So the things that cause sickling, dehydration, low oxygen, acidosis, these are the things that you get when you exercise. And so exercise is very important. I would recommend what Dr. Austin recommended, to go gradually, to increase slowly, always warm up, drink a lot. And these are recommendations for anybody who's exercising. This is what my doctor tells me when I have to start exercising. And so, I would definitely say that I think exercise is important for everybody. I think that if someone has sickle trait, maybe someone will feel better and have fewer problems with careful, graded, regular exercise. But again, I don't make real specific recommendations on that because it's not something I'm very knowledgeable about. And that's, again, why I insist. I don't insist, but why I encourage my patients to see primary care physicians. Primary care physicians know this better than I do. I'm not in practice, actually, so I'm seeing patients right now, but I would encourage, I think that the best care for someone with sickle trait is probably provided by a primary care physician with consultation from a hematologist to answer those questions that I said, to make sure the diagnosis is really right. If it ends up that the diagnosis is really sickle beta plus thalassemia, that's my patient now. And the primary care is still important, but now this patient might need hydrea, and that's something I really need to work on. I would say also, it's important to fund this research. Now, this isn't something anybody here can do, although, when you have a foundation, you can try to do that. Clinical researchers, doctors who do research and publish in journals, follow the money. If you get money for it, and, I was a researcher, and, the money didn't go to me. I had my salary, whatever my salary was, but if I could show my boss that I was bringing in money researching sickle trait, I can have a sickle trait clinic. And so that's more of a activism in a global level, but I certainly would encourage that.
Thank you. Thank you so much, Dr. Rob. I found that really interesting. Thank you. Thank you for being here, and I hope you feel better soon. Sounds like you're a bit under the weather.
Yeah, no, I'm fine, thanks.
Thank you. Thank you for that.
Thanks.
Our next panelist is my sister from another mister, my neighbor and baby sis, friend of 30 plus years. It's Danielle Housen. Yay.
Hello.
Hi, welcome.
How are you?
I'm good, thanks. How are you?
Yeah, I'm good. I'm good. Very tired at the moment, so hence why I've not been very, but I'm okay. I'm okay. Yeah, it's very interesting listening to everybody's problems that they've all had, and mine obviously go back from 30 years ago plus. My mum has sickle cell, as you're aware, and I have the trait. I also have a twin brother, and from a young age I've always had tiredness, shortness of breath, where my brother, complete opposite, no symptoms, fine, never had an issue. And through my teenage years, again, I was fine. I was, perfectly okay. And as I got to the age of 30, everything changed. I went abroad. I picked up an ear infection. I came back to the UK and I was like, okay, very dizzy. I mean, I've always had dizzy spells and heat stroke and things like that, and tiredness, but never to this extreme. I've had bouts where I've gone to the doctor and they've said it's vertigo. At one point they thought it was diabetes, and I was like, no, I'm not diabetic, because my dad is diabetic and my nana on my mum's side is diabetic. I was like, no, it's not. I know for well it's not. I've had, the bloods carried out for that. And when I went to Barbados, like I say, I got 2019, I want to say, yeah. So I was about 32, I just turned. And wow, what can I say? I came back, I had this ear infection, and I was like, oh, it'll be fine, don't worry. Started getting these really bad headaches. And I've always suffered with flying, the altitude, my legs go numb. I have to walk up and down the plane. I have to constantly get up every half an hour. And when I got back, I got worse. So my ear was getting worse, and my head was, but it was mainly my head that was the issue. So I went to the doctor and they confirmed I had an ear infection. So I was like, okay, they gave me some antibiotics, but I still wasn't right. And I think that listening to everybody and what I've got from this is we all know our own bodies. And I think to me, it's more of a frustration because nobody's actually listening. And if you've got a headache, if you feel warm, and I get that, like from what everyone's been saying, you've got to obviously get the right diagnosis and things like that. But it's hard. It's so hard. I mean, with me, everybody kept on saying to me, you've got an ear infection. You've got an ear infection. And I was like, okay, but I've also got the sickle cell trait. I've had numerous bloods throughout my life that have obviously, from childhood to being a teenager, I've been in accidents in the hospital where I've needed obviously blood, and it's all been, and then but for some reason being at 32, I've just had to battle, and I've had to battle. So I then started, like walking and like just normal general day to day, and I was collapsing in the street. So it got so bad that I could feel it coming, like, and my hands would start shaking. My head would start sweating, I'd start dizzying, and then I just collapsed. And I knew I needed to get somewhere to be safe, because it was not heat, because we don't suffer with heat in the UK that bad anyway, but it was the sweatiness. We obviously have, and then I was having like diarrhea. So mine was being sickness and diarrhea. And it was pretty bad, it took me like 2-3 hours to come round. I've been in places where, you don't want that to happen. It has happened in, like not shopping centres, but, you know, like general day-to-day places. And still the doctors were like, it's an ear infection. And then it went on for a few more months. I got another doctor. She then did a test and she was like, yep, we believe it's triggered with the trait. So I was like, okay. Then my bowel system got really bad to the point where I was driving with my nana. I could feel some sort of attack coming. I had to pull over and I then collapsed, but I have no recollection of it. I was being sick. I got out of my car. Was then taken to A&E. I was put on 4 fluid drips. I then had an MRI scan, a CT scan. I was in hospital the majority of the day for then the doctor to come up to me and say, well, there's nothing wrong with you. We're actually shocked that we're sending you home. So my view then was like, well, why are you sending me home? If you don't know what's wrong with me, then why are you sending me home? So they sent me home, and again, I kept going through these bouts and things like that. And then they actually started looking, because my stomach issues were so bad, with not being able to, like my toilet habits were so strong, you know, like I had to plan a route everywhere I went to make sure that there was enough toilets there and things like that. That I actually got passed on to a professor, because they actually thought it could have been stomach cancer and not anything to do with sickle cell. So again, I was put through various tests, endoscopy, colonoscopy, tablets I was given because I thought I had a stomach ulcer. And I was like, no, I haven't got any of this. I know it's not this, but nobody was listening. Then they said it could be the antibiotics that they'd given me back in the June. My stomach lining could be having an irritation to them. Again, I got one of then the best professors around. I've seen him now in March, and he's then looked at everything, and he's like, I should have been on folic acid for years. The vertigo spells that I've had are not down to, it is the trait by the looks of it. And it's starting to get investigated. But I mean, my story is obviously it's not as deep as yours. And obviously I don't know the different healthcares and, you know, how you all get treated in different parts of the world. But I just know one thing, it's very, very frustrating. And I think this group, it's bringing to light people are having the same sort of symptoms. People have got, you know, like, it seems like some people are getting to a certain age and these are getting more persistent as time goes on. And it's very sad, you know, like, I mean, it's great that everyone's here together, but it's very sad that we're having to go through this and we know what's going on, but nobody can give us a definite answer, all because it's the trait. And yeah, I'm not going to get too much into this because it does get me mad. It gets me really, really mad. And I'm not, yeah, I don't, yeah, like it's great, you know, and I think, I don't know whether Leah's still on the phone, but I think listening to her story, it was quite upsetting because, you know, you're listening to it and you could see the hurt. And I think, how long does this have to keep going on? How, do you know, like, why is this happening? Do you know, we're human beings. And I could go on a tangent for ages here, and I'm not going to do it because it's, you know, I think we've all been on this call a very long time now. But I think it's every time I was going to the hospital, it was, oh, you're diabetic. Oh, it's an antibiotics, an ear infection. It's this infection. It could be stomach cancer. It could be this. It could be that. And you get to the point and you're like, I mean, I'm very blessed because obviously we get more over here than what probably most countries do. But I just find it very, very frustrating and very upsetting that this is still going on. I mean, I'm still going through tests with, you know, like other things that they believed, which have all come back negative, which I've said to them at the time, 6 months, you know, into these tests, they're all going to come back negative because I know what it is. And one of my GPs, who luckily is clued up with sickle cell and sickle cell trait, she was like, no, it's not that, it's this. But we have to rule everything out. step by step, which they're doing, but I don't understand why people just don't listen in the first place, and it's just very frustrating, and it's I think very upsetting to see this. But then this community now, you're realizing that you're not on your own, because everyone seems to have these same symptoms, like there's people that I've listened, obviously, with people that have been pregnant. I mean, I've never had children, but you're listening and people are going through the same experience. I mean, mine obviously is very with my stomach, like not being able to control my bowels, and I get that people thought that could have been Crohn's, and it could have been, but it's not. And I knew full well it wasn't. People were putting it down to anxiety. It isn't anxiety. And I think it's just education is needed. It's needed more. And people need to listen. And yeah, I mean, like I say, I'm not going to talk anymore because I am very, very tired today and I'm not feeling 100%. So yeah, that was my little part. I don't know, Louise, if that's anything you wanted, but yeah.
Thank you so much, sis. I wanted to kind of say I can actually relate in brief before I introduce our next panelist, because when I was in crisis last year and over the years, I mean, this year has been a reflective time for me, and it is really upsetting. It's heartbreaking. It's painful hearing each individual story, and if not everything is exactly the same as what I'm personally going through, there's parts of it that are similar, and it's like I take what I can, and it's like, wow, there's things that I have experienced, and my bowel function is one of them, similar to your story, Danielle, because last year I had to ask for stool. I've never had a stool sample taken before. I've never had bowel issues before that I've felt, apart from whenever I would have full body crisis, not just in one area, my whole body would go into crisis, and it was a prolonged crisis. I'd have swelling of my stomach, and that began happening again just on its own, just a localized crisis where my stomach would swell and get really inflamed, and I started thinking something was seriously wrong, and I thought it was about gastroenteritis.
Yeah,
I don't believe it was, because last year when I went into crisis, it did the same, and then it was not normal.
I mean that's what was happening with me, because when I was collapsing, I was obviously having stomach issues, and it was cramping, and I had literally 10-20 minutes to get to a toilet, and it was coming from, and I think that's why I tell people that, because it's like you can't be ashamed, and I was taking spare clothes out with me. I mean, looking at, I've got a car, so it was in the back, but it's having to prep your whole life around, and everyone was saying to me, oh, well, it could be stomach cancer, and I'm like, well, hang on a minute, you've gone from having an ear infection to now you're doing the other scale, but then still nobody was listening to any. And I get that everything, and like I say, we're blessed in this country because we do have an NHS, and they were ruling things out, but still they were ruling things out like Crohn's, and I know it wasn't Crohn's. I've been surrounded by Crohn's. Diabetes, it wasn't diabetes, because my dad and my nana both have diabetes. I'm fully aware of them symptoms, both type 1 and type 2, fully aware of them. My mum has sickle cell. I've grown up with it all my life. I've been her carer since 7. I've lifted her in a shower. I've bathed her. And my mum even said to me, she was like, well, maybe it is the trait. She said, because it's so strange that now you've got to the age of 30 and everything that it was my mum that made me question it as well. I mean, I know she's obviously giving you advice over the years, but it was everything that was happening to me would happen to her, and she's full blown. So I was like, well, why is this happening to me when, like, earlier, and they were saying, oh, don't worry about it. It's, it's not going to affect you. It never is going to affect you. It's just, you'll go through life with something. It's a bit like when, I don't know, you've got a freckle or a wart on your face. Don't worry about it. You'll just go through life with it. But as I'm getting to 30 and over that age, okay, this is more serious now, because I'd never had these issues before. And the stomach issue to me is a very big one. My nana, who's 86, she has the trait. and she has stomach issues, and it's
Mhm.
just, yeah, it's just very frustrating, because when do you get listened to? Do you know? And
Yeah.
it's like you just said, your stomach, and everyone's quick to, you know, like, and I was given tablets for a stomach ulcer because my stomach was so swollen and it was hard to touch. It was really tender to touch, but it was
Yeah.
always when I was going through these episodes. And
Mhm.
I was like, you need to keep me in hospital. So, you know, when I have this episode, you can see it full force.
Mm.
Put your monitors on, take the bloods, because my blood pressure was dropping high, and then 1 minute it was going low. Then, so I was and I couldn't see. And I think that's when I started getting scared, because I
Yeah.
couldn't see.
Mhm.
And my hearing was going, you know, and I couldn't talk, and I'd lost all function for about an hour and a half. And then I came round and I was on a drip and I was on a monitor, and, you know, heart monitor. And I've always struggled with like breathing, and I don't have asthma. They've checked for asthma, you know, and yeah, it's very tough, very tough. But I
Yeah.
won't keep you rambling on, so sorry.
No, it's I think it's really good to relate and to talk, because I think we don't normally get chance to do this. So having these discussions and stating things that we've experienced is just like, wow. And someone's just put in, you know, that they've been through the same symptoms.
Yeah, I've just seen. Yeah.
It's really painful.
It's very frustrating, and I think
Yeah.
that, and I think everything that I'm getting from this group and seeing people, and no matter, you know, we're all from different parts of the world, and everyone has the same thing. Everyone's mad because nobody's getting listened to, and it's like, you know, the person that just popped up then, and I just saw it, you know, that makes them very angry.
Yeah.
And it's like, I don't know that person. I have never met that person in my life.
Yeah.
But it's so weird how we've both got the same sort of tiredness, stomach issues, this issue, that issue.
Yeah.
So why are we not, you know, there's all this research for cancer, and I'm not saying don't ever, you know, but they need to bring more, like I've said this to you on a private level, they need to bring more funding. They need to, you know, it's getting, it gets me very much. It gets, and I won't carry on, because if I do carry on, we could be here, and we'll be here till 8 o'clock Brit UK time, and we don't want that now. So, you know.
Well, I mean, we'll have a bit more of a panelist discussion after our next panelist comes on. But thank you for sharing your story. And if you're unable to continue being here, feel free to drop off, or you can just listen in.
I'll listen. Don't worry, I'll be still here. I've been here for the last 2.5 hours. I'll still be here. Don't worry.
I know it is a long one, but it's because I felt, you know, in honor of World Sickle Cell Day, Juneteenth for America as well. And I felt, you know, with Dr. Rob joining us and Dr.
Tomia, it's fine. I'm just, you know me, I'll just flitter in and out. You might see me eating a packet of crisp people, so I do apologise.
Well, feel free. You can put your video on.
I know. I just face it down. Don't worry.
Perfect. But thank you for sharing.
You're welcome.
And thank you for staying online as well. And yeah, joining. I'll encourage. I think if anybody else, I'll ask if anybody else in the who's joined us wants to just ask any questions live as well. That would be cool. So I will now hand over to Olubukola. She is a biomedical scientist, and she's a fellow sickle cell trait warrior. She said that she doesn't present with symptoms. However, that doesn't make you any less a warrior, sis. So welcome, and the floor is yours.
I think she's muted.
Can you see my slides now?
Oh, yes, we can. Yeah. Thank you, sis. Welcome.
Okay. Thank you. Thank you so much for having me.
Oh, it's a pleasure and an honor. Thank you for joining us.
Yeah. And I want to thank everyone who's been speaking on this platform. And I want to say thank you for all the stories we've heard. It's quite heartbreaking.
Yeah.
That nothing much has been done on this. I would say that is a shame. Myself, I'm just hearing this for the first time. You know, remember, Louise, that it was when we met on Black-owned economy that I got to know that are actually having symptoms.
Yeah.
I never had any symptoms, but yeah, I have a brother who used to complain of bone pains, but I have never heard of people having like crisis, like symptoms of, but I think you're doing a great job
Thank you,
for
sis.
doing the great awareness and making people to know that this is real.
Yeah.
And people are experiencing they're suffering this just to make up a story.
Exactly.
But and well done to all of you.
Thank you.
Yeah. So my presentation is just going to be short. My family experience is not about sickle cell disease. It's let me just quickly. Okay, so I will just quickly talk about my profile. I'm a biomedical scientist. I work at the Liverpool University Hospital in Liverpool here, and my husband is also a biomedical scientist. So we work in the same place. And we came to the UK, I think around about 15 or 17 years ago. I'm also, okay, yeah, both of us, we trained in Nigeria, and we both graduated the same year in 1993 at UCH in Ibadan, Nigeria. I'm also a professional counselor. I graduated in 2019 at Staffordshire University. I think my passion for supporting people has got hold of me to go for counseling. So I've been helping families and people who are victims of sickle cell disease to cope with their pains, to support them psychologically and emotionally, and also their families as well. So my husband and I, we are both sickle cell carriers, and we got married in 1997. Actually, we both knew that we were, or we are still carriers. But when you fall in love and then you've been there for a long time, and then you just moved on with it. So we just decided to get married and then hoping for the best. So we are both published authors, and recently we had an award because of our public awareness about sickle cell disease and blood donation. So we're giving the award in April, Health and Wellbeing Advocates 2021. So we're blessed with 3 kids, 2 girls and a boy. The first one is 23, the second one is 15, and the last one is 12 with 13 next month. So the first one, I think all of us except the second girl are all sickle cell. We have sickle cell traits apart from the second girl. So emotionally and psychologically, I was attached to sickle cell disease in a way because because we knew already that we were both sickle cell carriers, so we knew the implication of that. So, and having known that, it was traumatic. All the pregnancies were traumatic for me, thinking about whether they're going to be affected with sickle cell disease. So, in a way, I knew how what with each of them, but the last one was actually the boy was born here in Liverpool. The second one had no sickle cell trait at all, but she was always falling sick when she was a baby, because she was not able to resist malaria infection. You know, when you have a sickle cell carrier, you tend to resist malaria infection more than people who don't have the trait. So being a child without the traits amongst us, so she was always having malaria infection. I was even thinking maybe she had the disease. until she was tested that she didn't actually have the trait. So the last one, who is the boy, was born in Liverpool. And when he was born, after they've taken the, the prick tests and all that stuff, and then when they were coming to give me the results, I was expecting the worst to happen. And the community nurses that came, what do you call them now? Health visitors, they were reluctant about telling me the results of, the genotype of my son. And then eventually they told me that, do you know anything about sickle cell disease? Do you know anything about sickle cell group? Do you have symptoms? Do you know symptoms of if you have sickle cell disease and other stuff? By this time I was like, just let me know what it was. And they said, your son has a trait. I was like, oh, is that all? Because already I knew about the trait. So I just told them that, said that don't worry about it. It's what we can manage, So because of this, my experiences with although none of us is having the symptoms, but I knew what I went through going through the pregnancies. I and my husband, we started community engagement with people, and letting people know about when they come together as when they want to give birth to the children. So we set up community interest company called Path Lab Support in 2012, especially to support the sick people and the individuals and families affected with sickle cell disease. So our project, we do a lot of sickle cell awareness, blood donation campaign, and we also support children who have sickle cell disease in Africa. Mostly what we do in our campaign is about sickle cell prevention, encouraging young people to go for testing and make sure they know about their HBS status before they go into any serious relationship. So that since we know that this disease is preventable, and then we also post them to for genetic counselors as counseling, so that they'll be able to make informed decision. We signpost individuals living with sickle cell anemia also to sickle cell support group here in Liverpool, so they'll be able to discuss their pains together, share their experiences, and so that they won't feel alone when they're going through their pains. Like this. We work together with our blood donation campaign. We have signed up about 600 blood donors from BIM and Caucasian communities. We've done that not only by ourselves, but in also partnership with other people. We have not been able to do it on our own, except that we work together with other people. Liverpool Blood Donor Center for Community Blood Drive. So we organize blood drive for blood donation. Our next one is coming up next month on the 17th. We already have 16 people who have signed up to go for the blood donation. Since we know that people who have sickle cell disease depend on blood donation, we encourage people to give blood, also especially from BIM communities, because of our blood is best for us. So we encourage people to give blood. And we received a letter also from the NHSBT, which is a letter of support and anywhere we get to, when we tell them about our partnership with the NHSBT, they are always happy to work with us. We work also with community group leaders, faith-based group leaders, and also we are all over the place, any local event. So I'm just going to show you a few pictures of what we've been doing. They say my internet is unstable. I think you can still see me.
Yeah.
Can you still see me? Okay. Oh yeah. So we organized people to donate blood. This is one of our community drive blood donation. We work with the NHSPT, with community group. So I and my husband work also with groups of community groups, like we've been to Pakistani community, Somali community, we have been to Nigerian community to raise awareness about sickle cell disease and also about giving blood. Also, me and my husband, we work together with faith-based groups. The top pictures, when we had a stand with 5 groups of churches, we were there also to sign up blood donors, especially those who have not given blood before, and also regular blood donors. And the last picture was in a church where it says, what if blood donation is a part of your giving? Yeah. So also there is a music festival that happens every year in Liverpool here, and it's always attracting about 40,000 people in 2 days. So we were also there to educate people, recruit people for blood donation. And in 2019, I think that was the last one we had because of that. We couldn't go because of the COVID. On 2 single days, on one single day, we recruited over 100 people, being supported by the NHSBT, who provided the leaflets and the forms to sign. And we were able to recruit over 200 people in those 2 days. We also worked with Liverpool Sickle Cell and Thalassemia Support Group in Liverpool here. They also promote sickle thalassemia. So in Liverpool here, we have worked so hard. Any event, any local event, we are always there all over the place, just to talk about blood donation, about sickle cell disease, about how to make informed decision into going into before you go into any relationship. And lastly, because of our passion also to support people, my husband wrote a book about Beyond the Workplace, how to impact the community using your passion and career skills. And that can be found on Amazon. So the book is just talking about how you can use your passion, wherever you've got your career skills, to solve problems in the society or in the community. We've got something in us, every one of us, and we can use such skills to support other people. And that was published in November last year. I also wrote a book and was published in February this year. Take hold of your life, a simple mindset shift to empower you to be in charge of your life. Like I mentioned before, I'm also a professional counselor. I support people with their mental health issues, anger, depression, any sort of how to cope with pains and all that. Is all written in the book, how to accept your situation. And yeah, that's it. The book is on Amazon, and it's just a self-help book. It's about 9 chapters. And that's it from me. Thank you very much for listening. This question is a very short one.
It was fantastic. Thank you. Can you put the link to your book in the chat box, just so that everyone can access it, or we can share the link within the group as well, or feel free, if I tag you on the video, once it's shared in the group, just feel free to put the link, and then when it goes on YouTube, I'll make sure that that's also in there as well.
Okay, that's right.
Fantastic. Thank you.
Yeah, that's fine. But why do you want me to send it to you, or
You can put it in the, you can either put it in the chat group now, or it can go in the, and then anybody can copy and paste it into their own browser. I'm gonna screenshot with my phone.
Okay, I'll try to do that.
Okay.
If anybody has a question there, that's fine. Yeah. Thank you very much for listening.
You're welcome. Thank you. That was really interesting and fantastic work that you're doing. Wow, I'm blown away. I had no idea. I knew that you were an advocate and active, but I just never, because I'm new to this. As in, I've only just been sharing my story over the past year.
Yeah.
So it was something that it's wow. I'm so encouraged and blessed by what you're doing as well.
Oh, thank you.
Yeah.
Yeah.
I think we're still on your screen share, sis.
All right. I'm just trying to, I don't know how to remove that now. I'm just trying to remove it from the.
Let's see if it will let me. Let's see. Okay, perfect.
Okay, good.
Danielle, you look like you're falling asleep still.
No, my mum's downstairs listening to Boys to Men, so I'm gently just mellowing out
Trying
on
to stay
Saturday.
awake.
Yeah.
Wow, I'm really encouraged just being together with you guys. And I don't think Dom is here with us as far as I can see, because I was hoping he'd be able to join to share his story as well. But if not, it's absolutely fine.
Doesn't look like he is.
Is that a chat? Oh, he's here. He's here. Okay.
No,
Let me allow to talk and video. Let me see. Promote to panelist. Okay. I couldn't tell if that was him or not. So I think he's going to.
C Hall.
Yeah, I think that's Dom. Yay. Hey, Dom. Fantastic. So we have our brother in the house. Hey, Dom.
Hello, how you doing?
I'm okay, bro. How are you? Welcome. How are you feeling?
Could be better, as we all know.
Yeah, I hear you. Well, I'm gonna shut up and the floor is all yours. So go ahead and share your story.
All right, I started Sickle Cell Trait Journal back in, I think, around 2011 as a journal to collect information and symptoms from other people like me that may have sickle cell trait and different symptoms, different complications. To come to find out, I'm not by myself. Other people have the same stories. Back in 2010, that was a trait, right? I've been diagnosed with sickle cell traits, sickle cell disease, sickle cell alpha, not sickle cell, alpha thalassemia, mycritic, sickle beta thalassemia, trait. So I've been down the line. I done had 4 different hematologists. Actually, the first hematologist that I had, he eventually retired. That's the one that at least treated my pain situation that I was going through. It has now advanced, but once he retired, that's another thing I think that we don't talk about enough. Once our physicians retired, we have to start all over again. Or as Dr. Rob said, with our primary care physician or with our hematologist, after they retire, our situation is still going on. So we have to do everything, all the paperwork, all the explaining, going back all over our family history, our own history, all of that starts all over again. And it's depressing, really, to tell you the truth. None of that stuff follow us to other institutions. in some situations, when I do go see my doctor, I know they haven't read my report or my file because they will bring up certain things in my file, or they might not even remember your name. So basically just numbers. But yeah, I started Sickle Cell Trait Journal back then to collect information. To come to find out, I just started, or not just started, but eventually gravitated to the reports, to the studies about sickle cell trait, and come to find out, that's when I ran into more written material dealing with athletes coming down with sickle cell traits, more football players dying because of sickle cell trait, and at least being diagnosed as the cause of death of sickle cell trait. If y'all don't know, I'm in the United States. I'm in Wisconsin, Milwaukee. So it's well, at least here where I'm at, it's very difficult. And I've always said sickle cell traits need funding, good funding, that is, not a little bit of nothing. Every report that I have in the file section on Sickle Cell Trait Journal says that sickle cell trait needs more funding, need more research, all right? That's been going on for years already. So as we sit here and talk about our situation, and all the political stuff is being debated for years, we're still dealing with this, how our bodies feel. And on top of that, more people in the military having situations with sickle cell traits. And of course, Stanford did they study a couple of years ago saying that sickle cell trait has nothing to do with exertional sickling or anything else, kidney situations. In my opinion, sickle cell trait needs to be reclassified just for the fact of renal medullary carcinoma. And then on top of that, you can also go into the screening situations with diabetics, how it can, any hemoglobinopathy can throw off the screening of diabetes. So that also means that people are out here being diagnosed with diabetes, but may not have it because of a hemoglobinopathy. So that's another situation that's going on. I have some of my situations are, of course, sleep apnea, asthma, joint pain. I've had rotator cuff repaired, hernia surgery, ligament, and usually ligament situations, ligaments in my right ankle repaired. Another thing is stomach infections. H. pylori is another one. What else? Periodic headaches, of course, hypertension, diabetes. And of course, you know, diabetes to throw a lot of that stuff off, right? But mine is like pre-diabetes. So my numbers are not in the 300s or 200s or anything like that. And I don't need or take insulin. Another thing is the ligament that's in my spinal canal, that's thicker. So that's pressing up against my spinal cord, which is probably also causing more nerve pain. I have some days I have a right hip situation where the pain is so great in my right hip, I cannot function at all. That's one of those days when you had that pain where you just balled up in the fetal position and wait for it to go away. Here with the new changes in the opioid epidemic, it's very hard to even get into pain management, which you have a human right to get into, or human right to have access to, let alone opioids, which is the 1961 Convention on Opioids. That's international law that we seem to ignore here in the United States. So it's still a lot of work to be done. And a lot of people know how their body feels, and not even are they being diagnosed or being treated for whatever situation they have, yes, right. They're not being treated for whatever complaint they may have. Like Dr. Rob was saying, whatever their symptoms are, try to find the cause of it or treat it. I didn't go into this saying that everything was sickle cell trait, not at all. I went into it trying to figure out what the hell was wrong with me. Because I played football for 10 years, ran track in college, but I always had, I ain't gonna say complications, I'm gonna say injuries that resulted in those same complications, right? I had those same, like torn ligaments. Of course, football, you're gonna have injuries, but not to the extent that I had from high school all the way up. Even before football, I can remember in middle school going home after school, crouched over in pain, trying to make it home because I walked home at the time. And nobody knew what happened. Nobody knew what was going on. Even now, I'm 46 years old, and I go to the doctor, don't nobody know anything. I leave the doctor's office with the same amount of information that I had going in. And on top of that, we're in a situation where not only is it's not just African Americans that's dealing with sickle cell disease or sickle cell trait, it's other ethnic groups also. So it's not just African Americans neither. Any questions?
No questions from me. Thank you so much, bro.
And hopefully out of this situation that's coming out here today is to change the narrative, at least to be, like Dr. Rob said, be open-minded at least. Yes. The primary care physician I do have now is listening. I can say that. He is listening. Fantastic. Actually, the last primary care physician listened to, matter of fact, the first one primary care physician, how can I forget this story? The first primary care physician I had actually thought I had sickle cell disease. And he said, he actually called me on the phone. He told me he used to study it a little bit. I guess he changed his study when he was at University of, or in Illinois. And he said that he was getting trained for sickle cell disease, whatnot. And he said it looked like I had sickle cell disease, but the only way he didn't classify me as having sickle cell disease is because of I didn't have spleen situations, spleen surgeries, blood transfusions, and things like that. Mm-hmm. Although at the time I had a lot of emergency care visits for pain, chest pains, and things like that. Currently now with dilated cardiomyopathy, heart failure, and more than a few blockages in my heart. Mm-hmm. He said he would have, that's the only reason, from what he told me, he said that's the only reason why he didn't classify me with sickle cell disease. Now, what's the protocol for that? I don't know. I'm not a doctor, right? So I can't tell you that. Mm-hmm. Since then, I went to another hematologist that diagnosed me with sickle cell trait. After that, it was always sickle cell trait with something else. Sickle cell trait with alpha thalassemia microtic, or sickle cell traits with beta thalassemia traits. Now it's just the trait, mm-hmm. right? It's just sickle cell trait. And to come to find out, when I said earlier that I know they didn't look at my file, is when I'm referring to my last hematologist when I went, because mm-hmm. I had a DNA test, right? Through my hematologist at the time sent me through a baby geneticist, right? Went to them, talked to them. I did a DNA test. The DNA test came back. And said I had sickle cell disease with I was a carrier of sickle cell disease and beta thalassemia. That's what it was. Knowing that information, I asked my current hematologist about that. They didn't have the paperwork. They didn't have a file on that DNA test. But they were just saying it was already in my paperwork that it was sickle cell trait with alpha thalassemia trait. But the DNA test didn't say anything regarding alpha thalassemia trait, although they said I was tested for alpha thalassemia. And the test came back with beta thalassemia. Not beta thalassemia trait, beta thalassemia. And I know they didn't have it in their file because when the nurse looked it up, she couldn't find it. I had to go to my cell phone, bring up the document, and show the doctors then, the hematologist, what the DNA test said. Yep.
Can
So
I say something?
that's
Sure.
yes.
I too have had a beta globin genetic test. I have 2 rare intron variations homozygous for. In studies in the Middle East and in India, they classify that as beta thalassemia intermedia and beta thalassemia minor. The hematologist that I just saw said it's of no significance because she doesn't know the research. And even when I presented her with the research, she said the study wasn't big enough for her to classify me with sickle cell beta plus thalassemia.
Right. The study wasn't big enough.
Yes.
That's not accurate. So a patient with one sickle cell gene and one beta thalassemia gene has sickle beta thalassemia. There's no more research that needs to be done. That's an accepted diagnosis, and it's incorrect to say that that patient has sickle trait. It's the wrong diagnosis.
Right. So I'm in a position where I'm still looking for my third interpretation of that. I had the second on that current DNA test. I'm now into a genome project, which is dealing with heart disease and the sickle cell. And those scientists too said when they looked at the paperwork, it didn't look like I had alpha thalassemia neither. Because you got to, if you had a DNA test, you could send that over and they'll go through the DNA test with you. So like I said,
sorry, go ahead, bro. A problem I'm having is my DNA test. It was done, so I had my first consult with hematology back in December, and I was told that it takes about 3 months for the genetics to come through. And so the hematologist booked me in he said he booked me in for 5 months time, which would have been May. So I waited till the end of May. I even called the lab in April to find out whether the genetics lab down in Oxford, where it was sent to, had completed my test. They said they had. So I've been trying to contact hematology, and it seems like I've just gone off grid. And that's frustrating because even with work are like telling me, what's the plan? What's your treatment plan? What does it look like for you? And I'm like, I have no idea. And then they said, okay, so what does it look like for someone with sickle cell anemia? I'm like, I don't know, because we're different. Our bodies present different. If the tests are not done on time, we're not shown. Our blood work sometimes presents like it's fine or it's normal. And then hearing Dr. Maisha say that sometimes the red blood cells may not necessarily change shape, but they might be clumped together and paler in size and just kind of not present. So the hemoglobin's not carrying enough oxygen anyway in just normal round looking cells. So they might miss it at the time of taking our blood work. It affects everything.
So Mwape, do you have a primary care physician?
I do. I feel lost at the moment because my GPs are not hearing me. And when I mention sickle cell trait, they're just ignoring. I feel stuck.
So the way that you get around this
Mhm.
is you tell the physician, the primary care physician, you sent me to a hematologist,
Mhm.
a test was sent. I'd like to know the result of the test and what it means. Can either you interpret it for me or send me back to a hematologist?
Okay. Thank you.
That's the obligation, that you come with a problem. The doctor has to either figure it out or send you to someone who can figure it out.
Thank you. I'll do that. They say that they don't have the results. So and last year when I spoke to, I keep also not getting through to a GP. I'm in a bit of a strange, predicament, because I'm in an area where the closest general practitioner to me is about, I don't know, I'd have to get a taxi. It's not a direct route. Otherwise, I'd have to get 2 buses, one into town and then one out of town. It's a bit of an awkward place, and I don't drive. So I can't even change practitioner either at the moment, which is really frustrating. And then when I spoke to someone, at least I did get a nurse, an advanced nurse practitioner last year, and a pharmacist to speak to. But it's like, when I have to complain to even be put through to a general practitioner. And when I was in crisis and I felt my blood levels were low, the way I looked, my skin was so clammy, and when the crisis was so bad, that was when I had to complain. I threatened to complain, or I said, does it have to be that I'm going to die or something bad happens? And then this year, mentioning the most 2 recent young men who died from sickle cell anemia full blown was the only way I could even proceed with speaking to a nurse practitioner again or getting medication. And that seems to be a common problem that we seem to be all finding, where our practitioners are turning us away or not giving us adequate medication. And it's heartbreaking seeing somebody or hearing someone in that level of pain, where not even, I mean, paracetamol doesn't do anything. And I'm sure with many of us, our pain threshold is, I mean, our tolerance level, should I say, it's quite high. We can tolerate a lot of pain because we've had to, because it's not been believed for so long. But then there's so many other complications now. And it's absurd that we're just ignored. And it's only when it gets to the point of, look, threatening suicide, or saying to a doctor that I want to die, I just want to die, and having to voice those words. It's not a nice thing to say, but we've all been there. We've all been where we want to give up because it's so painful. I mean, I'm still having thoughts like that to this day, but I think having the group support, mental health is such a big issue. I know it's talked about with patients with sickle cell anemia as well. It's a huge thing because of the pain. But I think with the trait, it's something that we've had to go through in silence for so long and not be believed. And in some cases, I'm not saying it's worse than, because I don't want to, kind of compare pain, but I do feel that in a lot of cases where trait is brushed under the carpet, it can feel like it's so much worse because we're ignored a lot of the times. And even by physicians, I had a few people in the group approach me and say, we tried to ask our GPs, children are in pain with their limbs physically swollen, and you can see it visibly from some of the group members that contacted me. And they said, I gave them, everything is in my book that they need to take from a genetics counselor, that I put in my book for everyone to use to fight for themselves. And just to kind of, if their GPs didn't have any knowledge about circumstances where you can present with problems with the trait, say like low oxygen levels, high altitude, being cold, hydration, dehydration, overexertion, fatigue, and those are the instances that I was told. And they've literally, it's a professional thing. I've had to redact, but I've put everything that people with the trait need to be aware of in there. And I thought, well, this might help someone, because that was the only way I got my GP to even push me or refer me to hematology for further testing. Otherwise, they weren't going to do it. And I mean, they told me to stay away from the hospital because of COVID, and because I'm the trait, I just kept being told it's extremely rare, you know, it's not possible. And it's just like, well,
I'm sorry, those are two different things. Extremely rare and not possible are different.
yeah,
Someone's telling you that both things are the case, then that doesn't make sense.
yeah.
There's a lot of contradiction with hematologists. There's a lot of contradiction with doctors. They say one thing, and then on the other hand, they say another thing. And it gets frustrating because you're sitting there suffering, you're not being treated, you're being shipped doctor to doctor for all the comorbidities that you have. I'm not saying, and I never said that all of my problems are sickle cell disease or sickle cell trait related. All I want is treatment at this point. That's all I want. I want to live. I have children to live for.
Whether your symptoms are due to sickle cell disease or something else, they're still symptoms and they still need to be treated. I mean, it's fine to ask if it's because of sickle cell disease, but if the answer is yes, then it needs to be treated. If the answer is no, it still needs to be treated.
Yeah.
There are lots of other things that cause pain and fatigue, and lots of other people who don't have sickle trait have pain and fatigue, and their physicians try to treat them.
Yeah, and I mean, I just want to say, Dr. Rob, for the fact that you have kind of, and Dr. Maisha and Dr. Tomia Austin, you know, that we have people like you guys helping us and just kind of trying to help us and listen to us and hear our pain and say, okay, these are the things I recommend you to do. You know, the questions that we can be asking to push. We really respect that and really appreciate that, because it helps. Even, I mean, you might not feel like, I mean, I feel like I don't help anyone, but just knowing that someone's there listening and someone's understanding that, you know, I'm in pain and I experience these things, and it's not made up, it's not in my head, because so many times we get that, you know, it's psychological or it's in your head. And that hurts. It's very mentally, and I think emotionally, physically, it adds to the pain, because it's stressful. It makes you feel like there's no hope, I can't do anything. So we really truly appreciate all the advice and all the things that you can help us
So
with.
that's a diagnosis saying that, and first of all, almost every disease has physical and psychological components. Okay, so sudden cardiac death has psychosocial components. So to say that there's a psychosocial cause contributing to the pain it certainly doesn't mean the pain's not real. And it also doesn't mean there's not something else too. But that's why, you know, you take those questions that I had in my talk, and those 4 questions, and, you know, you keep saying, Dr. Well, you know, can you explain to me, can you show me the test result? Can you explain to me why this means I have sickle trait and why it doesn't mean I have sickle beta thal, or why it doesn't mean, you know, have you tested me for G6PD deficiency? Or you can just say, am I having hemolysis? So there are some lab tests we do that make diagnoses. So hemoglobin electrophoresis diagnoses sickle cell disease. But before you get there, you see that the patient has hemolysis. The patient's red cells are breaking down. That's diagnosed by seeing an elevated LDH, elevated bilirubin, decreased haptoglobin, and increased serum-free hemoglobin, and increased reticulocyte count. Those things happen no matter what the cause of hemolysis is. And once that's been identified, then that needs to be explained. And, you know, that's the way to go through it. If, you know, your doctors don't agree with the diagnosis, you know, that's like what I'm saying. It's, you know, I said, you got to, you know, just like my mother told me, you got to listen to the patients. They often tell you what's wrong. But if the doctor says, look, that diagnosis doesn't make sense to me, should explain why and say, so say for instance, your hemoglobin A was 97 and your A2 was 2%. And, I'd say, look, that's not, I don't believe that sickle cell disease is causing your symptoms, but the symptoms still need to be treated.
Yeah.
And another cause needs to be found. And if it's psychiatric, then that needs to be treated. There's a medicine we use in the States called duloxetine, which is an antidepressant, but it also has activity in chronic pain disorders. And so if I thought somebody had a chronic pain because of a psychiatric disorder, that might be the first thing I would try. I don't know if it's available in Britain, but I bet it is.
What's it called? I'll look. How do I spell it?
EU. Here, I'll write it in the thing.
Okay, thank you.
Dr. Rob, is that similar to venlafaxine?
Venlafaxine is another, it is similar. They're slightly chemically different, but venlafaxine also can be used to treat neuropathic pain, which, Mr. Hall, it sounds to me like what you have is neuropathic pain because you're saying about your ligamentum flavium being hypertrophied, very common in people our age, and causes neuropathic pain. And venlafaxine is a treatment for that.
Yeah, I've been on that one for the last couple of years.
Has it helped you?
Yes, it has, to a point to where I also have a spinal cord stimulator, but I actually one time was not given venlafaxine, and after I was on it for a while, I had to go get a refill, and it took me a while to get the prescription. Without it, it was unbearable without it.
Yeah, no, I have a similar kind of condition. I understand that. I use a different medicine, but I couldn't walk if I didn't have my medicine.
Right. And gabapentin. Gabapentin is another one that
Gabapentin is also good for that kind of pain, right?
28, 30, I think it's 32 milligrams a day. I'll take that.
Yeah, gabapentin is also good for neuropathic pain.
I've tried amitriptyline because I'd had what I thought was a slip disc injury because my GP said that to me a few years ago, but then I started having the same problems with my spine, and I do believe it was in conjunction with stress. It was stress related, and that seems to be one of my main triggers. I was overworking, really fatigued, running my business, as well as working as in a histopathology lab at the time, and I collapsed outside the lab and they sent me home. Thankfully, my colleagues who were doctors, they all rushed to my aid and they said, "You're exhausted." I got home, fell asleep, and I slept till the next day. And then when I woke up in the morning trying to get ready for work, I found that I couldn't move from my shoulders down. And my GP said, "Oh, it's a suspected slip disc." It was an old injury I had, but they never found a slip disc after they didn't do a scan or anything at the time. And when they checked the muscles at the sides of my spine, the erector spinae muscles, I don't know if that's how they're pronounced, but they were extremely, my back felt like a brick wall. It was so rock solid and I felt stressed.
That's what I have now with my back since 2010. That feeling that the muscle was so tight. It's called, I can't remember the name of it, but I was classified with that, the muscles being so tight, that main muscle in your back, that going all the way around my hips, that muscle is just hard as a rock 24 hours a day.
Yeah, I couldn't walk, couldn't get up. I'd be screaming in pain just to get to, you know, when you need to go to the bathroom in the night, I'd have to scream for my mom to come and get me up out of bed. And then I noticed a similarity. I was on amitriptyline for that, but then I noticed a similarity with the pain I was having, where I would have stabbing pains as well in my spine, and then certain sections of my spine would hurt. And that happened again when I went into crisis. So I believe that whatever injury I had in the past did sort of aggravate something, and it's now become something that I have to live with. And whenever I'm in crisis, I have those pains. And I'm having mild crisis pains on a daily basis, but it's just something now, I think, because it's been left for so long. It's just something I'm gonna have to just deal with. And I am trying like loads of nutritional supplements and researching as much as I can now into supplements that can just help promote healing. I don't think anything can be reversed, but it's
Well, the hope is it's got to change eventually, gradually. Something will come out of it.
yes.
What CPR I think just started in 1960. The germ theory, so it works slowly, but we might not be here to see the results of it, but it'll eventually come around if it's true.
Yeah. Oh gosh, guys, wow. Does anyone else have anything that they want to bring forward?
How often do you guys see your hematologist? Is it usually they tell me to come back every 6 months or a year?
Mm-hmm.
So
Well, in my experience, I had one hematologist who said sickling disorder, but he didn't want to treat. Basically, he told me, since Maryland is a medical cannabis state, continue using medical cannabis and it's ineffective for my crisis pain.
Right.
Wow.
It's not very effective for my chronic pain. So, and plus I'm of Caribbean descent, so I may have a tolerance, honestly, because I had been using it from a young adult for pain and sitting in silence in pain. So that's my truth. Also, when I went to the hematologist, the second hematologist, when she dismissed the intron variations and she says I have trait, she just blew me off and won't see me again. Now, when I sent all my records to NIH for a PKLR study, they're like, wow, we want you to be seen in our clinics for a second opinion so we can refer you to somebody who will see you. So I'm not being followed by a hematologist at this point.
you should see a hematologist. Mr. Hall, to answer your question, I have patients with sickle cell anemia. Usually when they would come to me, they'd be in bad shape. I would see them every month until I got things sorted out.
Okay.
The goal was ultimately to see them either every 3 months or every 6 months.
Mhm.
Anyone with a chronic disease, people with diabetes see their doctor every 3 months. And, there's not a lot of science behind that. That's just sort of custom, but that's reasonable. The most important thing, it's not even how frequently you're seen. The most important thing is to continue the primary care relationship with the physician and to keep going back and being seen as a regular appointment. I would never send a patient out of my office without a follow-up appointment. And, that's a little different because I was doing so much sickle cell disease and I was doing cancer and stuff like that. But, even someone who's well, we have this recommendation for an annual evaluation.
Right.
But
Had you ever heard of sickle cell Antilles? I think it's Antilles.
there's
Yeah. HBS
hemoglobin,
Antilles.
there's beta hemoglobin Antilles. Yeah, that's another compound heterozygous state. I have to say I'm not very familiar with how that particular one presents, but it's relatively easy to find that stuff out. For a physician, it's easy to find out. The resources are publicly available.
Now, would that be tested as the same as sickle cell disease?
I don't know the answer to that. Many hemoglobin diseases can be identified on hemoglobin electrophoresis, but some can. There's different kinds of electrophoresis you have to do, so it can get quite complicated. I used to work with my pathologist, to make sure that I understood what was going on. And when I needed something, the pathologist they didn't run in our hospital. I said, well, where can I get this? And the pathologist found out. So, there's more tricks to electrophoresis than I know about. But, and worse comes to worse, there's genetic diagnosis. And, genetic diagnosis has its own subtleties that you have to consider, but it certainly tells you what the gene sequence is. And, so again, the issue is, it's like any other disease state. You go to the doctor, you say, I have a problem. The doctor either fixes the problem, refers you to somebody, explains why it's not in your best interest to go any further. That happens sometimes, but arranges follow-up.
Yeah.
And that's, if I have a patient walk in with no medical problems for routine follow-up, I get the same amount of money for that I get for seeing someone with leukemia. And, I'm happy to see that patient. That's money in the bank. And, I'm being a little facetious, but the bottom line is the job is to see patients.
Right.
People, their panels are full. That happens a lot where I am in the Northeast. And, that's a problem. Every physician has to have his limit and say, I can't see any more patients than this. And, there is, like everything else, there's cherry picking. I would like all of my patients to be pleasant patients with simple problems that I can treat easily.
Right. Make your job easy.
Not all like that. And, part of the job is when the problems aren't easy to treat. And, so, but you can't just tell people don't come back. And the worst I ever say is I say, you don't need to see me. If you'd like to see me, I'm happy to see you, but I'm not really contributing anything. So, like when I get, and, someone might say that to someone with sickle trait who's, I could see a hematologist saying, look, I don't have what you need. What you need is primary care. You don't have to follow up with me. I'm always available to your primary care physician. He or she can call me. If you want to come back in a year, come back in a year. I see people who come back in a year for any reason. If the patient is perfectly healthy and says, I want to see you again in a year, I see him again in a year. And that's a standard in American medicine.
Yeah. Dr. Rob, I have another question, and I think, does anybody else have any other questions? Just write them in the chat. But I'm conscious of time, and I know that I don't want to cause anybody to feel worse than they're currently feeling at the moment. I know that all of us are managing our health as best as we can, but because we have finished earlier than I think it's 5 minutes earlier, 10 minutes earlier. Yeah, 10 minutes earlier. And we were booked for another half an hour, but I don't want anyone else to feel worse than they're currently feeling. So I was just thinking, and also Dr. Rob, I can hear your voice is also
Everybody
strained.
needs to hydrate.
Yes, I've been trying to look as professional on camera. But do you have any comment on medical cannabis? I've had a question from one of our attendees saying medical cannabis. She's put a question saying, is medical cannabis good or not good chronically?
So there's not a lot that's known about medical cannabis in the United States. The research is difficult to do and you don't get a lot of money for doing it. And because of the way we regulate marijuana in the States, it makes it particularly hard to do the research. I generally am not a big fan of medical pot for anything, but I had patients in whom other physicians had started it and it had worked. I worked in Rhode Island where it's a legitimate option. If a patient comes to me and says, look, I have a chronic symptom, you're not really treating the symptom, this is a legal option, I want to try it, I say, okay. And, you know, it's a little bit more caveat emptor. And I explain that, but, you know, that's the way that pot is set up in the States. And that's, you know, not for scientific reasons, that's for social reasons. So you know, no one really, I would expect that somebody who's doing a couple of joints a day, no matter why they're doing it, is going to suffer the adverse effects of doing a couple of joints a day. Now, the truth of the matter is, a lot of medicines cause adverse effects. I once gave a patient chemotherapy and boxed her heart and her kidneys blew up. You know, doesn't mean that she doesn't get the chemo. It just means this is a known side effect. So I think it would probably not be good to be on medical pot every day, but it's not good to be on narcotics every day. It's not good to be on Tylenol every day, or paracetamol, you guys call it.
Yeah.
So, you know, everything is risks and benefits. And, you know, I don't know what the regime is in Britain, but, you know, in the States, if it's a legal option, I'm not going to tell the patient, you know, the fact that they make me sign the paper is sort of stupid, but that's the way it is. And so I signed the paper. Unfortunately, sickle cell disease in Rhode Island was recognized as something that it's easy to get the state to approve medical cannabis. It's easy for multiple sclerosis, it's easy for cancer pain, it's harder for some other diseases, but I just fortunately didn't have to deal with that.
Yeah. Well, thank you. I guess it's one of those things that it's each to whatever they feel most comfortable trying or taking.
Because the government doesn't let the research, doesn't fund the research, doesn't let it be done properly.
Yeah.
And that's a political and a social decision. That's that's what we got to live with.
Yeah. Thank you.
You're welcome.
And I'm just gonna read out Leah's so yeah, I guess the oxygenation and ineffectiveness. So you tried it and discontinued medical cannabis because of oxygenation and ineffectiveness. So yeah, and I guess with one of the side effects with cannabis as a whole, I guess, is that fatigue and the tiredness that you feel with it. So if that's going to affect you, I wouldn't want to feel any worse than I currently do, because I feel sleepy all the time.
Well, it's not legal here, so you should be doing it.
Pardon?
It's not legal here, so you shouldn't be doing it.
I'm not saying that I don't do it at all. I don't do that now, but I have tried in the past, and I just, you know, peer pressure, and you try it and it's like, I can't handle that. So I don't know why anyone would want to do it. That was my...
I have patients who are on disability. They're not going to work. They're in pain. And if pot helps them, fine. I have patients who are employed. I had a patient who is a medical assistant. She's like, you know, they do drug tests at my job. I can't be on this. Or if a guy was a pilot or a machine operator, you know.
Yeah.
And you know, that's just how, you know, not every therapy works for everybody's life situation.
No, it's different over there because it's legal. Over here it isn't. So maybe
that's... So if it's not legal, it makes it more difficult.
Yeah. I can vouch for massage. I was a qualified massage therapist, but I can't do that right now. Massage helps with blood flow. It helps with, you know, getting the stiffness and toxin release as well. So it helps.
I used to refer all my patients, anyone who was willing, I referred for acupuncture and massage. And yeah, unfortunately, once COVID started, our hospital stopped providing those services. But Ade wrote in, I can't tell you what kind of massage. I'm not knowledgeable in it. There are some types of massage that are very deep, and there are some that are very gentle.
Yeah.
I would, for somebody with muscular pain, I would
Yeah, like sports
go on the
massage
gentle
and
side.
aromatherapy and Reiki. Yeah.
Yeah.
But I
Well,
can't
yeah.
make no specific recommendations. I'm not knowledgeable.
Yeah, I find I can't take massage doesn't help stop me having a crisis, because when I'm at a level 10 out of 10, I can't bear to even, my skin cannot be touched. I can't take the pain. And even if it's in the bone, the bone pain that I feel, I can't take touch all the time. So it depends on where I'm at. But as a maintenance in between, I can definitely, and I prefer a very deep, either sports massage, deep tissue massage, or even Thai massage. So they're all fantastic, and they really do help to just promote relaxation. But if you're prone to having a lot of pain and also the toxin buildup in the body, just be prepared to be knocked for 6, because massage is a healing therapy. Before you start feeling really invigorated, you may feel like you come down first. You might even feel like you have cold type symptoms after having a massage, because of the way your body is releasing the toxins and flushing them out. So just be aware of that. And on that note, sickle cell trait family, I thank you, and I'm really honored and privileged to be a part of this discussion today with you guys. Thank you for taking so much time out of your day and sharing in this. You know, let's help change the narrative one discussion at a time. And, you know, no blaming anyone, but just kind of, you know, just being able to be open. I think it's a good thing to be honest and open, and to share what we've been through, to hear from medical experts, because you guys are the ones who are helping us to cope with everything that we're dealing with, and hearing our voices. I mean, it means so much. So thank you so much, Dr. Rob and Dr. Austin, when you watch this back, thank you. And yeah, happy World Sickle Cell Day, everyone, and happy Juneteenth in America. Have a great rest of the weekend. I will send the link to you guys. I've copied it from Olubukola's book. If anyone wants to copy it, it's in the chat. And if anyone who's attended doesn't have my book, it's also in the chat as well. So yeah, it's 25% off on all Amazon paperback platforms until Monday UK time. I don't know what other times it is, but yeah, you can Google the time differences. I pray blessings, health, and yeah, changing the narrative together. Let's continue with this. And on that note, thank you for being here.
You're welcome.
Thank you, Monte, for organizing this. Thank you, Dr. Rob, for your valued information. And thank you all for all sharing. And I really appreciate you guys.
Likewise, sis.
Hope you get some answers soon, Leah. Good luck in your venture.
Thank you. Thank you.
Thank you. Bye, all.
Bye.
Bye.